Okay, good morning, everyone. Thank you for being here. We appreciate you all to be down here this morning. Today is January 25th. It is about 9:04. We're starting a little late. I apologize. If everybody could please stand for the Pledge of Allegiance and then remain standing for the invocation. And our invocation today will be from Reverend Edward E. Sabek from St. John's Assyrian Evangelical Presbyterian Church.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning, everyone, and thank you for having me here. Recently, I was reading a book. It's a collection of prayers of Puritans by name Piercing Heaven. And as I was reflecting on that, the prayer is not just a cliche or just some words. It's a piercing heaven that make a difference. And when the heaven is opened, the blessings will come on this board and in our community, in our county. And so with this, let us pray and ask God's presence with us. Heavenly Father, we thank you for this time, for this place, for this wonderful people, for this board. And we thank you, Lord, that you would bless this board and enlarge their territories. And we pray that your hands be with them and keep them from harm so that they will be free from all sufferings and pain. God of peace, we invite you to preside over this meeting, and may this board hold a spirit of solidarity in this room and work collaboratively on shared missions. Lord, who enlightens, we ask for your supernatural wisdom as this board makes some important decisions in this meeting, and help them to find principles that they all can agree on and put this into action. Help them to be unified in making the best possible decisions and to effectively carry them out. God of creation, please guide and help this board come up with effective strategies that can enable them to move forward as a team in a meaningful way. Help them to generate good plans that are practical, sustainable, and easily implemented. Almighty God, may your grace cover each aspect of this meeting, and we pray that all voices will be heard and that we will have a mindset of inclusivity, that may this be a safe space of people to express their opinions and a place where ideas matter more than titles. May everyone be engaged and involved, and may all concerns be addressed. May each member of this board feel valued, and we pray for peace, unity, and justice in our communities between brothers and sisters from different faiths, culture, race, regardless of political standings. Lord, we pray for the safety of our board members and our community in this COVID pandemic, and we pray that with all things begins with you, and with you all things rest. In Jesus' name we pray. Amen. Thank you. God bless.
Reverend, thank you very much. That was great. Okay, we are going to start off here with an update relating to our 2019 coronavirus. And I think we're going to start with our CEO, Jody Hayes. Jody, good morning.
Okay. Good morning, Chairman Withrow, members of the board, and welcome to everyone in the audience, and thank you for joining us this morning. As always, my pleasure to just kick us off. I'm not going to go through any slides myself today. I just want to do a couple of recognitions and at least answer one question from the public that we've received a few times recently. What I'd like to announce is, in terms of consistency for these types of updates, I'd like you to know we'll probably be in coming to do these updates probably every other board meeting for a little while. And, depending upon circumstance, if something significant occurs that we feel needs to come before the attention of the board, we'll certainly change that. But just going forward, please keep that in mind. So our next COVID update, I think, would be on February 8th, is about, I think, when the next plan would be. And I want to also acknowledge we've received several questions regarding whether or not the county is reconsidering our current state of emergency, recognizing that we haven't exercised any of those emergency powers in quite some time. And the answer to that question is, at our next board meeting, when we do provide an update, February 8th, we'll actually be presenting some draft concepts for what our COVID strategy looks like for the calendar year 2022. And in that conversation, we will definitely be visiting what is the intent and purpose of the ongoing emergency declaration. So that'll occur during that meeting. I want to recognize, as always, we have Dr. Julie Waishen-Pine and our Public Health Officer, and Marianne Lilly Tengowski, our Health Services Agency Director, to provide the bulk of our information today. But they also have a special guest with us today. And I'm sorry if I'm going to get this name wrong. I really do apologize. But Dr. Murali Nadu is this new CEO of Emmanuel Hospital, and he is here to join us and provide some information as well. So I'm going to go ahead and kick it off to the team. Thank you.
All right. Good morning, Chairman Withrow and Supervisors, Mr. Hayes and Mr. Bowes. Thank you for having us here again today. I'm going to start off with talking about our surveillance numbers. So as you can see from this graph, we've had quite a few cases reported that have pretty much eclipsed every single surge prior to this. Again, the blue is the confirmed PCR tests and the green are the probable or antigen tests. So we're continuing to watch this and monitor, but wanted to see the large increase of cases we've seen in the last couple of weeks. Here is our daily case rate that we show each time, the 7-day average, it's 7-day lag. And you can see as of 7 days ago, our case rate was almost 180 per 100,000 per day on average. And remember back in the blueprint and the tier system when we had to be below 7 to get out of purple. So we used to call this ultra purple, but it's, I think way past that. Testing positivity, again, 7-day average, 7-day lag. Again, our testing positivity has relatively eclipsed all of our other surges. And we can see that our positivity is over 30% for our PCR tests. We are doing a large test volume, bless you, of 758 tests per 100,000 per day, and that's just the PCR. So there's a large volume of tests being done, and you can see that very many of them are positive, over 30%. So we're going to continue on with talking about testing a little bit later. I brought this to show weekly case rate by age because you can see quite a few differences. At the top is our 25 to 34 in gray, followed by 35 to 44, and that's been pretty much the way it's gone through the pandemic. 18 to 24 being number 3. I'd like to bring your attention to 0 to 17, which is actually the bottom line. These are PCR tests only, and so 0 to 17 may be a bit less unrepresented here. I just want to make sure you know that because they are largely, many of them tested in school with antigen tests, and they do not show up on these graphs. This is PCR only. So, but still gives you a good look at of case rates by age group. Nice to see our 65 and older staying very nice and low. And then when we look at by race and ethnicity, again, what we see, some disparities here again, white being about half the case rate of Hispanic or non-Hispanic Black or non-Hispanic Asian. So some differences in our case rate and who is getting diagnosed by PCR at this time as well. We're bringing our wastewater surveillance again. As you can see, here's Modesto, Turlock. Got an update last week, Turlock. There's a lab going online, and it's taking a little longer than expected. It's being built in West Sac area, and they will be doing the Turlock testing. So hopefully by March, we will be able to see Turlock wastewater numbers continuing on. So those aren't coming anytime soon, but we still do see Modesto, and here's the curve here. It is not, that y-axis is a little bit different, right? They do it by half of 2 weeks ago, and then double 2 weeks ago. Well, we're about matching to a little bit less than 2 weeks ago, so we don't want to overinterpret this at time, but it is not, at this time, seeing a large increase in our wastewater from Modesto. They changed the way their website looks, and so this is a different look than I showed last week. So what we see here is they're showing Delta by proportion, by percent, and then Omicron in the purple box. So starting at the top with Delta, you can see that back in November we were 100%. Modesto is that dark brown line, and I wish this let me change colors because it's really hard to tell the difference. I put us in Merced in a Bay Area city, which just happens to be San Jose. I just picked one out because they're all about the same. And then, so you can see the brown line of Modesto, and then you can see it starting in January, and you can see that Omicron has really taken over. It came down January 2, we were still close to 20%, and it's down to about 3% estimated through wastewater at this time. Looking at Omicron, you can see that it has increased. We lagged a week or so behind the Bay Area, but you can see us in Merced pretty much modeling each other and staying together. We're the darker brown line that went up a little bit earlier. Omicron was estimated at 68% as of the data I got yesterday. So the question really is, what's the difference between the 68% and 3%? Because we've been looking at this and trying to estimate our percent of Omicron in order to use our monoclonal antibodies appropriately, because the number put out by federal HHS is 80%. So when Omicron reaches 80%, we would stop using the BAM-EDI and the Regeneron. So we were looking at this closely, trying to figure out this difference yesterday, but then the FDA has revoked the authorization for both BAM-EDI and Regeneron as of last night, so they can no longer be used in the United States. So we will be talking a little bit more about therapeutics later, but that decision was taken out of our hands yesterday. Looking at our hospital data, so here's the curve I show each time with hospitalized COVID hospitalizations in orange, those hospitalized and COVID positive, and the red being ICU. And you can see that we're getting we're getting close to our last summer peak at this time. So it was 290 yesterday in the hospital. Putting this, I used to show this, I don't know, a year and a half ago, but overlaying these two curves, what we talked about a little bit 2 weeks ago was the disconnect between cases and severity with Omicron and a lot of the immune evasion and the protection against hospitalization. We're going to talk a little bit more about that, but I think you can see very clearly here that hospitalization is not tracking along with cases like it did in the first three surges. So we'll continue to watch that as we move through this time. The last slide I wanted to show under hospitalizations is looking at ER visits for COVID-19-like illness. So this is our syndromic surveillance. So we have syndromic surveillance going on with all 5 of our hospitals, have been for quite a few years, well before the pandemic. And what this looks like is the chief complaint data for people coming into the emergency room. Chief complaint data is when someone asks you what you're here for, that's what you say. It's your chief complaint. And so I just want to show that this is the ER volume for COVID-like illness, what gets classified as COVID-like illness, is far superseding all other surges and is really impacting our hospitalization, so our emergency departments. So I just keep putting this out there. We put some messages out there of, please use emergency rooms for emergency rooms. Absolutely, if you need an emergency room, go there. But if you don't, call your own physician. There are some urgent cares that can give some, if that's the level of care you need. So really trying to ensure that this is ready for everybody in an emergency for those. So now I'm going to turn it over to Dr. Naidu to give us an update from the perspective of the hospitals.
Thanks, Dr. Vaishampayan. Good morning, Chairman, Supervisors. Thanks for the time this morning. I just want to take a few minutes and give an update on what we're seeing in our hospitals. I'm primarily going to share data from a manual, as you would imagine, but I had a chance to connect with my colleagues at our other 4 hospitals yesterday afternoon, and we're all really seeing very much the same things. I'll touch on what we're seeing in our emergency departments, what the inpatient hospital side looks like, and I want to talk a little bit about staffing. Starting with the emergency department, as you were just hearing from Dr. Vaishampayan, we're really seeing a very large uptick in the volume of patients that are coming through. And what's interesting is as we came back from the holidays and as schools reopened, we saw the percentage of people who were coming to get tested but then went home really go much higher than we'd seen in the past. So those individuals make up now about 60% of our ER visits. And the impact on our ERs across the county is that we are seeing an uptick in the amount of time people who come in and then get discharged home spend in the ERs, and that means they're waiting longer in the ERs. And we're also seeing an increase in the walkout rate. So both of those are pretty concerning from a community health service standpoint. Those numbers are up about 30% at Emmanuel, and again, not different in our other facilities.
Dr. Naidu, the walkout rate, just is that people that come in and walk out before they get any treatment at all? Is that?
That's right. That's exactly right.
So they sit in the waiting room and decide, I'm just going home? Okay.
Yes. In some cases, they sit in the waiting room and decide to go home from there, and once they're checked in, and in some cases, they start their treatment and then they leave. And, you know, we're seeing a backlog also as the labs get backed up and how long people have to wait for results, which contributes a little bit to that as well.
Okay. Thank you.
Yeah.
Sorry to interrupt you. Keep going there.
No problem. That's great. So, you know, that's really what we're seeing in our ERs. It really is impacting across the county in that we're now seeing increasingly that the ERs and the hospitals hitting the disaster level by the time we get to about the middle of the afternoon on several days in the recent past. And what that means for us is internally we're changing the way we're doing things once we hit that disaster level. But from the community standpoint, in many cases that's associated with our EMS having to go to a round-robin approach to the delivery of patients. So rather than the closest hospital, rather than the hospital of choice, if a patient's in an ambulance, then it goes to whichever hospital is next in line. So obviously that presents some challenges as well. On the inpatient side, we have seen an uptick in the number of patients, not quite to the level as what we've seen previously in the pandemic, but we are approaching that, and that number continues to grow. What is unique is that the number of people in the intensive care units for COVID has lagged a little bit more than we've seen previously. So more people are coming in, getting their care, and ultimately getting discharged home, but it is pushing our admission numbers higher. Notably with Omicron, we have people who are more frequently being identified as positive after they came in for something else. And that's still an important challenge from several standpoints. We obviously have to isolate those patients differently than we would have otherwise. But also it makes whatever they're there for often more severe and requires that they're in the hospital longer. About 3/4 of the patients that are coming in and needing hospitalization for COVID are unvaccinated. Of the remaining quarter, about 2/3 are fully vaccinated, not boosted, and then the last chunk there are the vaccinated, boosted part of the population. It's particularly notable that we are really seeing some tremendous impact still of the vaccine efforts that we've had here in the county. I was actually on the way in listening to some data that the California Department of Public Health was presenting, and this data that lags a little bit because it's coming through a study, so it's really up to December data. But if you look at unvaccinated individuals relative to vaccinated, they're 17 times more likely to die if they get severe disease. And compared to boosted individuals, it's actually 53 times as likely to die. So really dramatic impact there. Lastly, I want to touch on staffing. All of us in the hospitals, and frankly across the economy, as you know, are struggling with staffing. We are doing many things to address that. We're all using bonuses, wage increases where we can, and trying to get our partners with staffing agencies to make sure that we can get more help in. Again, that's across the organization, and it continues to be, for us, a challenge because, you know, right now we're down to a place where we have really our core group that continues to come in, take the extra shifts. They're tired, they've been working hard, and so from my standpoint, what keeps me up at night is ensuring that we can support them, that I can support them, and that we're able to continue to support the community and its healthcare needs. So all of these things are what we're dealing with at this point across the county.
Very good. Thank you very much, Dr. Naidu. Any questions for Dr. Naidu while he's up here from anybody from the board? Okay. Thank you very much.
Thank you.
Okay, I'm going to continue on. I thought I would give a little bit more update on some of the things that are being done for the hospitals. Besides, staffing support that the state can provide, another thing we've done is tried to work with the state to build out our skilled nursing facility capacity. We know that often patients that need skilled nursing facility post-hospitalizations are waiting for discharge because skilled nursing facilities have the same staffing issues as everyone else. And so a couple of weeks ago, we worked with the state to build out 20 beds in one skilled nursing facility, and build out means they staff them and they do everything. There's another request to build out 10 more, and we're working on that, and hopefully that can help our hospitals at least get some of the patients moving through the system. It actually impacts all the way back to ambulances waiting on the wall, because then people are waiting in the ER, and then people are on the floor and they're waiting for discharge. So the most that we can expedite discharges in a timely manner, it really does help the whole system. So there's a lot of work at all ends of the spectrum trying to ensure that beds are available for everyone who needs some. So that continues to be work underway and be moving. There was, I think we talked about it last time, also a large hospital number of beds that were built out around the state. And those are still, they've been built out. There's many. There were about 100 in San Joaquin County, but they have pretty much filled up as well. So continue to work with our skilled nursing facilities and moving patients as quickly and as they're needed to be moved. So that work will continue. I wanted to bring forward a couple data that came out recently. I think it's made the news a lot about protection from COVID-19, and there were three technically MMWRs from CDC. That's the Morbidity and Mortality Weekly Report. And I thought I'd just talk real quick about two. So this is the one that was presenting California and New York data, and I think you've seen a lot of press about that. So what we see in this one is that dark blue line is the unvaccinated, and this is hospitalizations. New York wasn't able to match up their hospitalizations, but California was. So this is many hospitalizations. I forget the total number, and we can go look it up. But so you can see during the time of Delta, so this is Delta, and you can see the dark blue line at the top is the unvaccinated. The cluster of three lines at the bottom, if you look real closely, you can see there are three different ones. It's the vaccinated without previous COVID, it's the unvaccinated but previously infected, and it's the vaccinated and previously infected. And you can see them all clustering. If you look real close, and what they saw was the unvaccinated but previously infected at that very beginning, that when it was under alpha, vaccine was better protection. But I have to say, with immunity waning and everything, and this is hospitalizations, you see them being a little bit flipped there, and previous infection being just a little bit under vaccinated with no previous infection, and of course the best being previously infected there and vaccinated as a line. But really quibbling about very tiny amounts of data when it's really compared to those who are unvaccinated and not previously infected. So we can really see who's being hospitalized for COVID-19, certainly in the time of Delta. The second study looked at vaccinations and looked at boosters and the effect of boosters. And so as you see here, the graph on the left is cases and the graph on the right is deaths. And so you can see is the cases, and this will include, it's unvaccinated, it includes previously infected and just anyone who's unvaccinated. And then you can see the lines at the bottom, fully vaccinated at the bottom, we're looking at the cases. And then the booster came, and you can start seeing some lines for boosted in October. So it's showing that booster clearly decreased risk of infection this was during mostly Delta, but starting to be Omicron, and you can see it's still giving protection with the booster. When you look at deaths, you can see extra protection also with the fully vaccinated and boosted, so what we call up to date. So again, really focusing our work on vaccination and boosting to protect people against death right there on the right. I think it's clearly showing. I hadn't brought vaccination numbers for a little bit, so going into who's vaccinated in our county by age group. So I think you can see that we've continued to see increases in all levels of, all age groups, I should say. So if you look at those 65 and older, we know are at high risk for severe disease, and you can see between all those receiving at least a single dose, we're well into the 90%, which is great. 50 to 64, well into the 80%. So again, some work to do yet, but making some very good progress there. So overall, 5+, you can see getting into the upper 60% for at least one dose, and about 57% for fully vaccinated. I put the 18 plus in there because a lot of times when the federal government talks, they talk 18 and older, they talk adults. So seeing what it is for our county is always helpful to compare to the rest of the country when they're talking that way. If we look at boosters, because I brought back who's received a booster, and I'm sorry, these are percents, and I should have put that in. You can see that about 40% of our people, Stanislaus County residents who are age 65 and older, have received their booster. 25% in 50 to 64, another still at higher risk age group, and then 11.6% of our 18 to 49. So continuing to give boosters and see improvements in these numbers. Bringing this up, you see there's a dip as you look at our vaccines administered every day. A dip for Thanksgiving, then a dip for Christmas and New Year's, then there's a dip at the end, which is probably a lag in data. But you can see we're averaging about 1,500 doses a day in the county, so still pretty good vaccination ongoing. Lastly, I'm sorry, I knew I was going to forget that. So in this previous one, I wanted to talk numbers too, because we always talk in percents of population, but I wanted to bring forth the numbers. So at this point, we have more than 298,000 people in Stanislaus County, age 5 plus fully vaccinated. So it's 298,000 that were vaccinated in about a year. We have over 57,000 age 5 and older who are partially vaccinated, and there's been over 84,000 boosters given. So that's a lot of vaccines, and it's really a tribute to all the vaccinators in our community to get those vaccines as quickly as they've been getting them out. So I just wanted to bring forward the numbers as well to show the volume of vaccines. And then finally, I'm going to say some things about treatments. So again, Bamedi and Regeneron no longer able to be used. Molnupiravir, Paxlovid is the two oral medications that we discussed 2 weeks ago. The IV remdesivir and sotrovimab is the one monoclonal antibody. The current allocation that we got yesterday, 520 of molnupiravir. They come in cases of 20, so we got some increase there. Paxlovid, again, an increase of 1 case, so 120. And while they haven't told us and confirmed and committed, we've been getting these. This is our third allocation, and we've been getting them about every 2 weeks. So that might be a 2-week supply. It seems to be holding out that that's what it is. Sotrovimab is weekly. They've been giving that weekly, and we had a pretty good increase, 120 that were allocated yesterday. And that's for the week, as I said. IV remdesivir is commercially available. It's a fully approved medication. It can be used under the study we talked about last time, outpatient, but it is IV 3 days in a row, so that is a barrier. But that was off-label up until yesterday, and they expanded the approval for remdesivir to include outpatient use for mild to moderate COVID-19. So it is something that is available in the United States, in Stanislaus County. If people order it, it's available. It's used widely in the hospitals when they get hospitalized as well, so it's available. So that's what we have for the treatments. And I wanted to talk a little bit about who's at risk for severe disease, because we keep saying if you're at risk for severe disease, call your healthcare provider for these treatment if possible. So who is at risk for severe disease? And I took this list off the CDC website. People who are older age, certainly greater than 65, pretty much greater than 50 is at increased risk. Age less than 1 year, that first year of life, it's always those extremes of life. So the age 1 year have a higher incidence. Unfortunately, there's very little treatment for a child that's less than 1 year, so really need the parents around them to vaccinate to protect that little baby. Obesity, which is a BMI of 30 or more, the definition of obesity. Pregnancy, chronic kidney disease, diabetes, immune compromised. And I think some people don't realize the full extent of what this means. It can be either from a disease process, or it can be like, leukemia, or it can be from the medications you get, the cancer chemotherapy, the medications you get for your rheumatoid arthritis, for any of your rheumatologic disease, your autoimmune diseases. They're suppressing the immune system, so that makes you immune compromised. Heart and vascular disease, lung disease, sickle cell, and neurodevelopmental disorders. So it comes down to nearly any medical diagnosis. So those are the people at risk for severe disease, and the more of these you have, the higher your risk is. So if anybody has any of these and tests positive for COVID, you need to talk to your healthcare provider immediately, because you can see that these have some timing around them for the medications within 5 days. And I will turn to Mary Ann.
Thank you. There's certainly a lot of attention right now, understandably, on testing, so we wanted to provide some information today, some updates. So we wanted to start by just explaining that there are really two types of tests available, the PCR test and the antigen test. And there are advantages and disadvantages of each. And we've said for a long time that the PCR test is really the most accurate, reliable test. But the downside is that it's a local specimen collection. It goes off to a lab. It takes time to get that the lab result. When there's not widespread transmission, that's been about a day. When we're really in a surge, it can grow to 3 days or more to get that result. So the antigen test is often quite sought after because it's a 15 to 20 minute rapid result. But it's not as reliable. When we're in times of widespread transmission, a positive result from an antigen test is pretty reliable, while a negative is a little harder to interpret. The other thing, especially during this last month with the at-home tests, that we wanted to make sure that everyone recognizes there are really two different antigen tests authorized. One is, and they're different. One is the at-home over-the-counter test that you can use in your household. The other is an antigen test that can only be used obtained by a healthcare provider with a particular lab license. So if there's availability for antigen tests by a healthcare provider, that doesn't mean it's an at-home test. They're different. So I want to make sure that the folks know that, particularly because the at-home test availability is pretty scarce right now. The other thing we just want to touch on, because there's been a little bit of buzz out there about whether to use the at-home test by swabbing the throat, and we're advising that that's not what you should do. It's not authorized that way. There's been a study that shows that's not as effective. Also, if there was going to be genome sequencing done to determine the variant, the throat swab, it's not effective. We can't do that. So really, those tests should be used as they're authorized as a nasal collection. Okay, I imagine everybody in this room has seen or heard something about this, but just to make sure, the federal government released this free at-home test kit availability. You can go online. They've also added a phone number that you can call if difficulty going online, and it's four free at-home test kits to each address. I believe if an address has already been ordered, you can't go back in and order again. It's by address, and they're saying 7 to 12 days. They should be in your mailbox. So encourage folks to do that. We wanted to make sure that everyone knows that we really have worked hard at ensuring that there is testing availability for the community, and these are the PCR tests. So it's not the rapid 15 to 20 minute result. They are the perhaps more reliable. Before, and we've talked about we've brought this before many times, where the testing sites are and whatnot, but we wanted to talk a little bit about capacity and the expansion that was done, and throughout the pandemic, I want you to know that there has been scaling up and down, so it has changed over time. But if we just look at that time period between the Delta surge and Omicron, we had far more capacity than was being used. So we started at a place where the existing sites and supplies and whatnot was greater than the demand. And once Omicron got started, boy, we saw that really pick up quickly. You know, when one week it went to 60%, 80%. And I want to say, too, that less than 40%, it varied by site, too. Some went down as low as almost 20, some might have been a bit higher, but roughly a little less than probably 40%. So what we have a mobile van that goes to a different community each day. The flyer's on our website to say times and location in those communities. That's Monday through Friday. And they have had about a 400 tests per day capacity. Out at the Community Services Agency site on Hackett Road, again, Monday through Friday at about 400 test capacity. Briggsmore, the same thing. That was Wednesday through Sunday. We've made a deliberate effort to make sure that although not all the test sites don't run 7 days a week, some are 5, some are 6, but we made sure that there is availability every day of the week, not necessarily at each location, but every day is covered. What you see there in the bold is where all the expansion occurred. And I mentioned a couple weeks ago that the expansion was, some had already taken place, some was in process. We don't staff these testing sites. It's not county employees. We help arrange through a couple of vendors. So it's their operation, it's their site, but we help with where they're going to be and putting in a request to expand. Generally takes a week or two to be effective. So you can see that between January 9 and 16, this expansion was implemented. So the work for it started prior to that. In series, the capacity was doubled from 165 to 330 tests per day and added a 6th day. Salida, we already had 2 lanes, so couldn't really add more capacity, but added the 6th day so that open on Saturdays. And Turlock doubled the capacity and available Sunday through Friday. I mentioned there on what's italicized there, we don't really we don't arrange for these locations, but we're deliberate about coordinating to ensure that there is access in all the communities. So I just mentioned that too, so that folks know that they've been running at about 500 capacity per day. Our goal has really been same day or next day availability. A week or two ago, and we were randomly going out to see, we maintained that through this. Not necessarily at every site, if you wanted the same day or the next day at a particular site might not be available, but you have to go and look at the different sites, so that takes a little bit of time. But you could find a test availability same day or next day throughout this, and we're already beginning to see a little bit of drop in demand. So same day is pretty accessible. So this is what I showed before too. This is just from our website. If folks are looking for test locations, please look at our website. You can links right there to go in to register for an appointment. And then we haven't talked about this for quite a while, so and we made a change. So I wanted to bring this to your attention. That very early on in the pandemic, there was real concern for, you might remember, it was test availability, there weren't enough supplies, it was difficult. We wanted to make sure that the first responder workforce had the support needed so that we were ensuring that, that capacity for the community. So we set up an expedited specimen collection process. It was a referral through public health for first responders, and we used one of our county primary care clinics to do that. It was also in the beginning sometimes even used by healthcare workers when supplies were really thin. We've continued to have that availability for first responders. Then in 2021, the at-home test kits. Some of the agencies also made their own arrangements, so I'm not here to tell you that we provided all of the first responder testing, but this was a service that was available. We also had arranged with a separate lab. When the lab started backing up, we arranged with a separate lab in the Bay Area for just these so that we could maintain a 24-hour turnaround time. Then with the at-home test kits, we know those were being used by many, And then when they became very scarce, we were getting an awful lot of calls. I know some of you did too, looking for at-home supply, and just scarce. So we pivoted in that county clinic, and we're now offering the rapid antigen test for first responders, which is, we know right now with so much widespread transmission, it's really important that they get the diagnosis and the return to work negative test as quickly as possible to maintain the staff capacity. So that's available. We've promoted it back out to all the law and fire and ambulance service to make sure they know that that's available. So wanted you to be aware of that. This is just a look of our website. There's still an awful lot of information on there on the monoclonal antibodies. We have, if you click on that, it shows you those who's at risk for severe disease, like Dr. Weishenpine showed. So encourage folks to look at the website if they need information. We're just going to keep on. We're going to keep on trying to kind of hammer this, and hopefully, as we come out of this, hopefully the community will pay even more attention. Because if you're really not doing the things that you could be doing to improve your health, you are, increasing the likelihood of illness. Live healthy and be well. And if you haven't been vaccinated, please go to My Turn. If you haven't been boosted and you're eligible for booster, please go to the My Turn website and schedule an appointment. And if you're homebound, if there's mobility issues, there's still availability, and you can still use My Turn, or you can call our public health line, and we have a small team that will go out and make those arrangements to give the vaccination in home. And with that, I will stop, and we'd be happy to answer any questions you have today.
Very good. Thank you very much, Marianne and Julie and Dr. Naidu, for coming here today. We always appreciate what you guys are doing. I know we tell you this every time, but we just are proud of all your hard work and know how much hard this has been for you, for everybody, but especially you guys having to come up here and do this So anyway, thank you very much for all you're doing. Okay, any questions for Marianne or Julie?
Just a comment, Mr. Chairman. Thank you. Marianne, Dr. V, thank you for your report. And I'm glad to see that our time is dropping in the first responder testing. In my prior life, I think I was patient 0 when that first began, and it took 7 days to get that test result back. So I'm glad to see that the 24 hours turnaround is good. And just, I think I'm going to throw this out at you, and I don't know what your response will be, or if you know, but what is occurring in the UK with the drop of the mask mandate? What test results or studies are they doing to make that decision? Do you know?
I don't. I'm sorry.
Okay. It's curious to me, and I haven't been able to find it in that decision. Okay. So I was wondering if you did.
Yeah, no, I actually hadn't even heard anything about it yet, so I'll go look at the UK.
Thank you.
You know I usually do.
Thanks, Buck. Manny?
Thank you, Chair. Thank you so much for the presentation. Just on one of the slides, it's encouraging to see that we're getting more allocation of the different treatment options. I know there's only a few select sites. I think last time we said there's about 3 that are doing it. And then how are we gauging the utilization of the allotments at each site? Are they all kind of doing equal since they get equal disbursements, or are we kind of monitoring, this facility is only seeing 15 patients a day, this one's seeing 100 a day. So have we kind of monitored that, and our allotments going to be more aligned with utilization so that the facilities that are really getting a good response to these treatments as far as utilization, that we're going to give them more, or is it just going to kind of be, we got 450, there's 3 of us, so you each get 150?
So there's a couple different ways this happens, and I'll start, and you fill in whatever I forget. So the monoclonal antibodies are separate, right? Because they're IV infusion now. They're not. You could do some sub-Q for the ones that we can't use anymore, so it's IV right now. So we have to have outpatient IV infusion centers for these. And so those are being done by providers in the community. And in general, they put in their orders, and then we look at what we have and we allocate them out as best as we can. So they use them all. Then the oral meds go to pharmacies. These are pharmacies, so you need a doctor's prescription. You go to the pharmacy like you do for any other medications. Like I had said, the state had partnered, it's a federal partnership as well with CVS and Rite Aid. So they'll be at 5 select CVS and Rite Aids, and the physicians should know which ones they are. Utilization, there's some attempt to track at the federal level so that they're supposed to update the website every single day on their inventory, but that's not as reliable as we would hope. So it's just at its infancy, right? They've just had 2 allocations so far. The 3rd will be coming out this week, and so I think that's some ways we can work on improving so that we know, because it's really hard right now to know which one has some, how are they being used, who are they being given to. We don't have any of those data from these pharmacies. Is there?
But I know it's difficult anytime.
And then how do we allocate them out to the pharmacies? Well, since there's 5, and so far we've gotten, like, say, a Paxlovid 5 cases, they've each gotten 1. So they've each gotten 20. We look at distribution in the county of cases and population, and then try to match it to the pharmacies. These pharmacies were selected by CVS and Rite Aid as pharmacies that could take the volume and work with these. So and then we just try to allocate it based on distribution and ensure access throughout our county the best we can. Does that make sense?
It does, and I appreciated what you said towards the end, that the county's monitoring it, because just going to be honest, sometimes when you have a federal database or a state database, it just makes it a lot more confusing and a lot more time consuming. So if we have some kind of internal mechanism that we know that we're making sure that everything's being done and utilized properly, I think that's probably serves our community and our residents better.
Right. So we get to say where they get shipped to, right? But after that, we're blind to their utilization. So like I said, that's someplace where we have to work, because we are discussing this, how we can better look at this and find out who are they using it all, and who are they giving it to, and ensuring that it's really access for those at high risk.
And that does with the oral meds. I think
Yes.
the IV infusion one was one that, I'm just candidly speaking, I had one of the providers reach out to me and said, I do this much a week and everybody else does this. I said, I think our public health department has a very good system, but I just wanted to be able to answer that this is what we're doing, because the way it was explained to me, and I know CEO Hayes was brought into the conversation as well, was, some are doing 10, I'm doing this much, and I'm not getting this, the allocation is the same. And, obviously, I would hope that's not happening. If somebody's utilizing more than another, then we want to send it to where the most amount is helping the community. So.
Right. So we're giving it, everybody's using their allocation. So yes, it's getting out into the community. So we try to make sure it's diverse providers and diverse populations. And you can pull out Kaiser as an example, right? So they need a proportion to the proportion of their insured population. And so Kaiser gets some. So that's the way we look at it, and then ensuring that there's access. Yes.
I appreciate it. Thank you so much. Thank you.
Thanks, Mandy. And just a quick follow-up on the oral treatment. Those are just going to CVS and Rite Aid. Those are the only pharmacies that are getting it. Is that right?
Correct.
Okay.
Right now, that is true. We are hoping to expand it sometime, but we need supply to increase because, like I said, it's 5 cases. Now this time it's 6. So we can't break up those cases. So,
Sure.
yeah.
And that's not our decision. That's a federal decision, right?
It's between the federal government and the state government, yeah.
Okay. Okay, because I know we've got, in our disadvantaged communities, we have these small local pharmacies,
Yes.
I know, out on Crow's Landing Road. It would be nice if they could have
Yes.
some of those there. I don't know where the closest CVS and Rite Aid's there, or if those in these areas even go to. I know this isn't your guys, nothing you can do about
Right.
it, but it's just, it's strange that that's the only pharmacies that can have these right now, when there are these local ones that certain, and especially in our disadvantaged communities, that people are comfortable just going there only. So, anyway,
Right.
nothing we can do about it, but just complain
Yeah.
about it, and hopefully
Yeah.
we.
Yeah, well, we need more supply, and we need providers. I mean, we've sent them, the location of the pharmacies, the website where they can check availability, all these things. So the providers can hopefully send them to the pharmacies and get their medications. Yeah.
Very good, thank you. Okay, Chance.
Thank you, Mr. Chair. And thank you to this great presentation. I want to thank the CEO of Emmanuel for joining us today and also giving us some insight on what's going on in our local hospitals. I did just, I guess, have a broad and general question is, do we see a threshold yet, an end game to this, in the sense of what are our numbers? What do the percentage of our population that need to be vaccinated or need to receive the booster in order to return to some sort of form of normalcy, or at least the normal of yesteryears? I plan on getting the booster eventually. I hope to get it this week or next week. But is there going to be another booster with another variant? And when does, I guess, the merry-go-round stop?
Okay, well, that's a really, that's like the million-dollar question that, everybody's talking about and everybody has opinions, right? So you're going to get my opinion. So this is going to be really difficult. If the rest of, so we're not a herd, right? As I was talking this week, we're not a herd. Any cattle farmer will tell you we're not a herd, because we mix in and out every single day, and nobody does that with herds or flocks of chickens or any other poultry. You just don't do that. If you have new animals coming in from outside, you quarantine them and keep them separate. So herd immunity is really a concept that doesn't work in our global society, right? I mean, if it does, we need the whole world at the same level. So as long as the whole world isn't at the same level, we are going to continue to have a lot of variants emerge. I think as we move on, and again, you're just getting my opinion, we're going to see more variants emerge, right? Are they going to have more immune evasion? Are they going to have more severe? Are they going to be less severe? I mean, these are all the unknowns, and I think that's what makes it so very hard to talk about what we're going to see. I think if it was status quo, like I think I said a little bit 2 weeks ago, and it was Omicron, and with the level of immunity we have in our population, my whole goal is to keep our healthcare system going, right? And so when we reach levels, when we get 300 or 400 in the hospital with the same disease, that makes it really hard on top of their regular hospitalizations. And so when we reach the point when that doesn't happen and everybody has some level of immunity, and that's one of the reasons I wanted to bring those slides forward, I mean, that looks really promising, then we're pretty good. So it's going to, I think that's a good chance to get back to normal, but then it depends on the whole world being there and what variants emerge. So that's not an answer, but that's, as best as we can look forward, because there's just way too many unknowns.
No, absolutely. And honestly, I don't think, like you were saying, there's no concrete answer to that. That's all just opinion and hypothetical. I just think you get to a point where, I'm going to get the booster. I'm going to have 3 jabs. That's great. Is there going to be a 4th and 5th? And how does it just become like the seasonal flu shot? Right. How do we get to that point?
Yeah.
And that's why I'm saying there has to be an end game. There has to be, okay, we've done that, and it is just going to be a part of how we live our daily lives. But that doesn't mean that we can inhibit how we live our daily lives. We have to be able to function. People have to still move freely throughout society. And I think that's everybody's goal.
Yes, it is.
So, and I do have a just follow-up question in regards to testing. I would be interested in see how we compare in distributing our testing as compared to surrounding counties. I would like to kind of just see where we're at as far as if we're succeeding in that or kind of lower than expectations.
I'm not sure. I'm sorry. I'm not sure I understand with the PCR testing and the testing sites and the capacity.
Just distributing the tests to our local communities, whether it's the pharmacies or just, I guess, how are we doing with the PCRs as compared to San Joaquin or Merced or Tuolumne? How are they doing as compared to our data? If there is any data out there for them, so that we can kind of compare and contrast.
Is the question how many tests are being offered in our community versus other communities? Is that the population?
Yes, that would be fair.
We can try to figure that out. I know we know our numbers, but we may be able to ask those other counties.
Yeah, I would just be interested. Are we, excelling in that capacity as compared to Merced or San Joaquin or Tuolumne or, whoever. I'm probably not Santa Clara, but I would just be curious of how we are doing in Stanislaus County as far as testing in the surrounding counties.
Okay. We'll look and see what data we can come up with. I know one of we'll certainly work on this. Let me say that. One of our immediate challenges is going to be a large part of the testing framework right now is built completely outside of our system around pharmacies. Like, I know many of the tests I've done myself personally, I just go into CVS, do the test thing, line up, all that. We're not going to have any data on that, but let's just see what we can come up with. Thank you.
Okay, thank you very much. I appreciate it. Thank you again for your presentation today.
Okay, thanks, Chance. Vito? No, okay, nothing there. All right, again, thank you guys very much, and thank you. Just one quick thing that, and I thank, again, Dr. Naidu for coming from Emmanuel Medical Center. And it seems like one of the points there in your presentation, Dr. Naidu, is a lot of people come to the hospitals maybe not necessarily need to be at the hospital with regard to, and that's natural, right? The fear we all have, geez, I'm getting it, I'm going down and hit the hospital. And so, but it sounds like we need to encourage people to maybe go to their physician initially. Go to your physician, which would really probably help the hospitals with their overflow, which will help people with other issues that are going on at the hospitals and for them to be able to get treatment. And so it sounds like that's just kind of a message that tell me if I'm wrong, I don't want to say something out of turn here, but it sounds like that's what we'd encourage people to go to their individual physicians to begin with, especially with this variant, and let it go from there based on their physician's advice as compared to our initial panic to hit the hospital. So anyway, thank you guys very much. Great presentation, and we appreciate all you're doing. Thank you. Okay, before we move on to public comment here, I want to introduce our former supervisor here from District 5, Jim DeMartini is here. Jim, could you stand up so we can all recognize you here? Jim's coming to the mic. We're in trouble. Here we go.
Well, I'll just say hello to everybody. I'm here for 5 days to visit family and friends and to start on my taxes with my accountant, so, which we did yesterday. It's a pleasure to be back now. I live in income tax-free Nevada now, and so different place to live. Finally started working on my model railroad that I always wanted to do but didn't have time to here. Now I have time.
Well, great, Jim. It's so good to see you. We envy your life now, and we're glad you came back, and don't be a stranger. Keep coming back and seeing us here.
Yeah, I monitor your meetings every week and look forward to your State of the County address. I know how much you look forward to that.
And you might also add, you're celebrating former Supervisor Dick Monteith's 90th birthday, right?
Yeah, that's right. I took Monteith and his wife out last night. He'll be 90 next week.
Yep.
That's great. That's great. And Jim, we all just so much appreciate all your time that you served here in this community and all the efforts that you put to try to make this a better place. So thank you for all your past work.
I enjoyed it there, but you know, the hostile business climate, high taxes, and left-wing politics forced me out of California. So. Well, anyway, glad to be back here. I'll be here for 5 days, and after your meeting, I'm going to go off to Patterson and Newman to visit people. So,
great.
Thank you.
Thank you, Jim. Say hi to Ann for us.
Okay.
Thank you. Okay, we are going to move on to our public comment, and it's at this point where this is for any item that's not on the agenda, for anybody to come up here and speak, up to 5 minutes, and we will start off here with Steve Allen. Steve, good morning. How are you?
I'm well. Good morning. I have a bad habit of leading in too close, so if I blast everybody, just tell me and I'll behave. Right about there, okay?
Yeah, that's perfect.
Good morning to you. I'm here today as a concerned citizen in Modesto, California, and I'm very, very worried about the state of the justice system and law enforcement in Stanislaus County and in Modesto. I think that to anyone who pays any attention at all, it's indisputable that we have grave concerns. I don't want to spend too much time talking about the very scandalous career of, is it Burgett or Burgett? I believe it's Burgett, but we have a DA with a very, very checkered record. And I just mainly want to talk to you about my concerns that justice will not be served in the case of the Modesto Police Department's murderous, repeat 5-time killer cop, Joseph LaMantia. I don't know if each and every one of you has seen the body cam footage, but Joseph LaMantia arrived to a church where somebody was just hanging out getting space. He drove around the facilities, parked his car behind a building, came out from behind a corner, yelled, I don't remember exactly what he says, but he did not identify himself as a police officer. He did not identify the person that he was there to kill. Obviously, I don't read his mind, but if I judge all of his actions and the hard evidence, it's undeniable. I know a lot of people would disagree, but I'm not going to play games and pretend like I didn't see what I saw. Very, very clearly. He pops around the corner and empties his clip into Trevor Seaver within seconds. Why? Why would he do that? There is no rational explanation whatsoever other than the one I've drawn, the conclusion that I've drawn, is that he wanted to kill him. A large part of that had to do with information that was being circulated that has since been established as false. So when we have a police department that's spreading information that somebody has posted on social media that they want to kill cops or even something that implies anything of that nature, how do we respond? Well, what Joseph LaMantia did was, I'm going to take one of those sons of bitches out of this world. I'm going to go there and kill him. When you watch the video, you hear the sirens in the background. The other squad cars were really, really close. In a matter of seconds, you would have backup. Trevor Seaver was unarmed, posing no threat whatsoever. Joseph LaMantia was like reporting, like whatever the code is for like a situation. I don't know how all the language works, but he was reporting that before he had his gun in his hand before he got out of his car. He had to reach over, put the car into park with his other hand. He pops around the corner, kills Trevor, because he wanted to. A large part of that has to do with how the department handled the misinformation. So there was an investigation into this supposed social media post, and then it was dismissed. There are a lot of different details to this case, and a lot of reasons why I think it's perfectly emblematic of our problems. I just come here to beg of you to please make it your personal concern that we have a safe community and that we have justice when this community is not safe. That means that Alex Bettis, who was formerly under investigation along with LaMantia in one of his previous cases, should not be employed in the district attorney's office as an investigator. Brandon Gillespie said that there were 3 independent investigations a while back. And then as he explains, 2 of them are in PD, one of them's the DA's office. So what I see is a bunch of friends with very questionable careers backing each other because they're cops. That's disgusting, and it has to change. So first of all, I'm basically, the main thing I want to impress upon you is that I beg of you, if you have any moral goodness, you need to use what influence you have to make sure that Joseph LaMantia is tried for murder. Manslaughter does not apply to one person intentionally, unlawfully taking another individual's life. That's not manslaughter. That's nonsense. He needs to be tried with murder. It's plain and simple. It's obvious. Additionally, there are a lot of things that need to change, and I just would implore each of you to consider public safety the goal and not just backing police in everything that they do. Joseph LaMantia needs to be tried for murder. Thank you.
Thank you, Steve. Okay, next up, I have Samuel Bossart. Samuel, how are you?
I'm doing well. Thanks, Terry. Sitting in a different seat this time, I see.
Sure.
Good morning, members of the board. Just wanted to come here and say that we've been calling COVID-19 an emergency for a long time, as far as declaration and all that. And in my view, it's past time to stop. Definitions of emergency from different dictionaries include an unexpected and unusually dangerous situation that calls for immediate action, an unforeseen combination of circumstances or the resulting state that calls for immediate action. An urgent need for assistance or relief. I can keep going on. There is a specific definition in California Emergency Services Act, Title II, Division 1, Chapter 7, Article 2, Section 8558, defines local emergency. When looking at it, this has gone on very a long time, and I appreciate the questions that the board and feedback that they're giving. Thank you. For example, Chance, you're my you're in my district, and I appreciate that. You asked, well, where does this end? Where's the exit? Yeah, but anyway, that's about all I have for now. Thank you.
Okay, thanks, Samuel. Okay, next up I have is Sarah Short. Good morning, Sarah. How are you?
Good morning. How are you?
Good.
So I'm going to talk about some personal experiences I've had with this emergency order going on. I'm going to start with the most minor. One of my boys, he was running around being a crazy boy, and he ran into a pole saw, cut his foot. So I take him to our urgent care, where we have established care. They wouldn't let us in. It was only COVID patients until noon at the time. There was nobody in the parking lot. My son's bleeding from his foot. We couldn't get in. I was so pissed. I'm so angry. I went home and I glued his slit back together, and I taped his toes together so it wouldn't split open anymore. The next one, my other son. One morning we couldn't really wake him up. He was extremely lethargic, could hardly keep his eyes open. So I went to Sutter again, except to the one that we would have been allowed in, because only the Modesto facility was allowing people that weren't COVID. They made us sit in the parking lot, and it was the middle of summer. We were sitting there with our windows open, and somebody came over and told us we had to roll our windows up because we were being hazardous to other people. Okay. So finally it's our turn. We go up. Again, there was one other car there. We go up. First thing they want to do is a COVID test because he threw up. My son is losing consciousness, and they want to COVID test him. This is ridiculous. So I demanded I see the doctor, and the doctor said, oh, you need to get him to ER. Turns out he had low blood sugar, and that's why he couldn't stay awake. And they wanted to COVID test him. Like, this is ridiculous. The next one, my other son, he had a low fever, and he was up all night crying of his ear hurting. He's 6 years old. He could tell me what's happening with him. So, okay, ear infection. I call his pediatrician, try to get in, get some ear drops, give him some relief so we could all sleep. And we weren't allowed to see our pediatrician because he had a fever. It's a COVID symptom. His doctor called me really late at night and told me next time don't say he has a fever if he hasn't been exposed to anybody. I was like, you want me to lie? And she's like, I can't see my patients then. A pediatrician can't see her patients. That's a problem. We can't even get basic care. Nothing. So I ended up calling around to urgent cares. And the one I called asked them if we're going to be treated like we have a plague if we come in with fever. And I actually happened to get the doctor to answer the phone, and he said, this literally our job is to treat sick people. Bring your son and we're going to take care of him. It almost made me cry. Have somebody finally hear me. My son has an ear infection. Come on. It's not that hard to deal with. The next one. My dad had a surgery. And then his entire leg got swollen. Classic sign of blood clots. So I told him, go to the ER. I wasn't allowed to go into the ER with him. My dad knows nothing medical, so I'm the person that fights for him. They sent him home. And in their imaging, they have studies from before that show 1 non-occlusive clot to 3 occlusive clots. And they sent him home. Part of that is negligence on the hospital and the doctors, but the other part is because I couldn't go in and make his voice be heard. It wasn't allowed in. So I sent him back. And I had to write out what he needed to say. And he told them, and he called me, he said, they're trying to send me home again. So I got on the phone with the doctor, and I said, don't you dare use some choice words. He was admitted, and he had to be admitted for days. I think it was 7 days. That could have killed him, all because I wasn't allowed in. So the next one, I'm running out of time here. The next one is the most heartbreaking. Both my grandparents got sick, not COVID related at all. They got pneumonia, and it turned to sepsis pretty quickly. We were allowed 15 minutes each with my grandmother.
It's okay, keep going. Sorry.
15 minutes each, because it was end-of-life visits. We had 15 minutes to say our goodbyes. I don't wish that on anybody. And then, she did get a little bit better. My grandfather made it home. And so we decided to have a hospice bring her home so she could spend her last days with my grandfather because he couldn't spend time with her. They have been together since they were 12 and 13 years old, and they're 85 and 86. My grandfather got just a few hours to spend with her before she passed away. I hope nobody has to experience that ever. Somebody they've been with for that long just gets a few hours. It's not right. None of this is right. We can't get basic care. And if they would have been COVID positive, nobody would have been allowed in. They would have died in the hospital alone. That's not right. The emergency needs to end so people can say their goodbyes, hold tight to their loved ones. Thank you for letting me go over.
Thank you, Sarah. We're sorry for your loss. Okay, next up, Joni Creep, I'm sorry. Why don't I know this? I am so sorry.
It's okay. It's not a common last name.
How are you?
No offense taken whatsoever. I'm a little better now. I already shed a little tear, so I think I got that out of the way. Thank you to the gentleman. That was so kind. So I'm a little bit shocked that Dr. V doesn't even know that Prime Minister Boris Johnson has effectively ended all COVID mandates in the UK. Anyone else a little shocked by that? How is that possible? She's our public health officer. So anyways, while I was sitting there, I thought, well, maybe it would be a good idea for me to email her the UK Health Security Agency's COVID-19 vaccine surveillance report from week 42, which is their last and final vaccination surveillance report. They're not going to be going forward with that anymore. And let me just read one sentence from the end of the summary. Neither of these models will be updated going forward. This is due to these models being able to unable to account for the interventions that would have been implemented in the absence of vaccination. Consequently, over time, the state of the actual pandemic and the non-vaccinated pandemic scenario have become increasingly less comparable. All right, so now I'm going to read you guys. I wish I could read this whole thing. So I also emailed to Dr. V just now. It's an open letter to Governor Gavin Newsom, California Department of Public Health Director Thomas Aragon, Secretary of California Health and Human Services Mark Galley, State Superintendent of Public Instruction Tony Thurmond, all California County public health officers, and all California public school superintendents and boards. This was written by Jean Noble, MD/MA, Associate Professor of Emergency Medicine, Director of COVID-19 Response for the UCSF Emergency Department. Jennifer Nguyen, MD, Pediatrician, UCSF Benioff Children's, I never say that correctly, I should know this, Children's Hospital Oakland, Alta Bates Summit Medical Center. Vinay Prasad, MD, MPH, Associate Professor of Epidemiology and Biostatistics, UCSF, Hematologist, Oncologist, San Francisco General Hospital. Jarrett Moyer, MD, Surgery and Bioengineering, UCSF, and Laura Chinavaso, something like that, RN, BSN, Alameda County, Disaster Relief, COVID-19 Response. I wish I had time to read this whole thing to you guys, but I won't be able to get through the whole thing. We are writing to you today as public health and medical professionals and as California residents since this pandemic began. We have been living under the most restrictive COVID-19 policies in the country. For those of us in the Bay Area, we continue to navigate the most restrictive policies in the state. These restrictions persist despite California's high vaccination rate and low COVID-19 hospitalization rates. California's COVID policies have failed to evolve with the advent of highly protective and widely accessible vaccines. Our restrictive policies that have caused considerable collateral damage throughout the pandemic have long lost their justification as necessary for prevention of serious illness and death. These pervasive policies continue to negatively affect our professional and personal lives without clear benefit nor any end in sight. And thank you, Chance. Present policies have driven thousands of people from this state, some of my loved ones personally, and from our public schools. And we will continue to lose many great minds, great businesses, great families, and great individuals if current policy is not righted. We are particularly concerned about the toll that our state's policies continue to have on our children and teens. They go on and on and on and on. I wish I could read you every single word, but I'm not going to have time. But let me stop right there. We are particularly concerned about the toll that our state's policies continue to have on our children and our teens. By now, you guys know that I stand here before you pleading for my son, my teen. I will not stop. I have found my voice. I'm getting past the tears, sometimes. We can be firm, we can disagree, but we have to come together for our children. It is past time. It is past time. You guys are not a danger. The cloth over your face, oh my goodness, I could talk to you for, I'm a nurse. Oh my gosh, I love it. I love the science behind it all. I love the studies. I love the statistics. You guys don't need those. You don't need them. And I don't mean that disrespectfully at all. I really don't. I hope you hear my heart on that. I have nothing but respect for you guys as you lead our county. You are amazing men. So thank you for what you're doing, but I hope that you hear us. I hope that your eyes are finally starting to be opened to the bigger picture. And our kids, there are nothing more important than our kids, you guys. So, thanks.
Thanks, Joni. Okay, next up we have Milo Shelley. Milo, good morning. How are you?
Good morning, Supervisor Withrow. This has been a while. I've had the pleasure of meeting with you before, along with Vito, and some of the new faces here. So I haven't been here since City of Modesto, and we had some development war, and the county on the development war, and some water rate issues. But anyway, thank you for having me. I've been a resident of Stanislaus County, Modesto, for 42 years, and from time to time have gotten involved with community issues. I think at my age it's important for older folks like me to get involved and to take a leadership role when so many other people, when you're building families and working day to day, really don't have time to get into it. So I'll try to make this as quick as I can. My concern is over the recent garbage rate increases. A couple of points. Cost rate setting, less service. Second, efficiency. What are the metrics? Are we efficient or are we not efficient? One size fits all in how we're approaching refuse collection and disposal. Competition. We have basically, I think, a duopoly here. For those that are attorneys, you'll know that that is kind of like a monopoly, where if one person's rate is, one organization sets a rate, the other organization follows suit, and it's kind of like, it's really not competition, it's kind of laddering between the two. So that is a concern. And that gets into contract setting. Do we have contracts that really foster competition or encourage perpetuation of what we've always done? There's transparency, meaningful public review, meaning that in lieu of a PUC or other type of body, it might be beneficial to the community to have a community board, and people like myself, whether it's attorneys or CPAs or waste management people, that can get together and review independently what the recommendations from county staff are. Communication, I think we can do better. I think it's incumbent upon the group here to reach out to the community and to community leaders within their constituencies to explain what the rates will be and why. They may be justified. I can't tell you. I've asked for the cost data. I've talked to Mr. Condit's office. I will wait for that if it can be had. But it brings up, again, question, are these figures really audited? Do we really have some control over, or is it, basically an argument, well, we need new trucks and we need new this and so forth, but if you have a cost-plus business, kind of a duopoly, it spirals up and up and up. So, I mean, there are some very sophisticated waste management companies, and Waste Management is one of them, and I'm sure they have metrics that we can look at to see what we're doing. Is it the best way that we're doing it? And, these are some things that are on my mind, and I think they're on the mind of our community. And that's about all I have.
No, that's good, Milo. If I could, good questions, and we have all of us up here have had the same concerns that you do. There's a whole process, and we need for you to be able, I know it sounds like Buck has spending some time with you. We need to really get you to sit down with maybe Rob here from DER and Will, and we'll sit down and we'll talk, if you have the time,
Sure.
And we could show you the process that we go through. There are audited financial statements that the garbage companies are required to present to us. There is a formula that we have that was put together years ago that we look at. All these questions that you have are good questions, and let us just show you, show you what we're doing and how we got to where we are. None of us wanted to be here. This is a state mandate, as you know, but there are answers to all your questions, and at least you can see what we looked at and what was involved with us before we finally made a decision as to what those rates would be. And it was a long process of answers, of us gathering answers to all those type of questions you asked. So if you've got time, we'll set up a meeting and do something like that.
I would like to do that. Thank you very much.
Perfect.
Mr. Chair?
Yeah, Vito?
Is there also, there's a solid waste committee. I'm not even sure who's on it, because I've never sat on it, but.
Yeah, the solid waste.
Yep.
Okay.
It's just the financing side?
Yeah, okay.
Okay.
Okay, so we'll get you.
I mean, it's obvious, it begs the question, when you get something that's a huge increase, if somebody came in and said, well, your property taxes are going up a bazillion %.
Right.
The wheels would come off the place.
Sure.
I mean, it's kind of the same idea, these are outside of the norms.
And so we need to sit down with you and show you what we've looked at and got there. So Rob has just stood up in the back there, Robert, and he will
Thank you very
get us
much.
started, and we'll figure out how to get a meeting and get
I'll
you in
let
here.
someone else take a deal. Thank you very much.
Thanks, Milo. Okay, next up we have Jan Higgins. Jan, good morning. How are you?
Good morning. Thank you for having me.
Thanks for coming.
It's a privilege to be here. I have 4 topics I'd like to discuss with you. The first topic is regarding children and oxygen. The second is regarding healthcare workers. The second is regarding ostracized physicians. The fourth is the severe reactions to COVID vaccines. I am a registered respiratory therapist in the state of California. First of all, vital signs for children are increased. Their respiratory rate is higher and their heart rate is higher. That means their consumption of oxygen is higher. Okay, so any kind of mask you put on a child is going to impede their respiration. It's going to impede their breathing mechanism. I recently had an experience. I was waiting for a GI procedure, and just to test myself, I had a surgical mask on, like what you're wearing, the ones that open on the side. I had a pulse ox on my finger, and I was looking at the vital sign machine, looking at my heart rate, looking at my oxygen level. It was 90%. My normal, I was just resting there. My normal oxygen saturation is anywhere from 94 to 98%. So right there, just in a resting position, I'm down by 4%. And I don't breathe as fast as a child does. So you're actually impeding a child's breathing more with a mask on. Okay. With emergency training for children, oxygen is the most important thing for them because of their higher consumption. Respiratory therapists go through three tests every 2 years. Neonatal resuscitation for babies, PALS, which is pediatric, advanced life support, and then adult life support. People over the age of 70 to 80 breathe faster as a whole. Normally they're up to like 24 a minute, and also children breathe faster. So, but with any general rule of any age is that if your lungs are compromised, if you have asthma, you have COPD or smoke or whatever, your heart rate will increase because your heart's trying to pump that oxygen through your body quicker. Okay, so just keep these in mind. So for the last 2 years, children have been wearing masks, not been able to see people's expressions. When they're at school, their social experiences have been compromised. Now, what they're doing over this last week, I don't know if you've seen it on television, but now we're wearing N95 masks. They're called N95 masks because 95% of the air that comes through this mask is compromised, 95%. So what you're going to be doing is impeding breathing even more. This is what all doctors, nurses, and respiratory therapists have to be mask fit with this mask every year to make sure it fits them correctly. It's got the metal here, it's got that fits under here, and I only wear this for hopefully about 10 minutes at a time when I go into a COVID patient's room because it's hard to breathe through this. You're not breathing well. Also, you cannot understand somebody who talks with one of these on. And they're trying to get us to wear these all the time. This is not a good thing. This is overkill. Okay? Well, when I started my work, I would start at 7 at night, and by 10 o'clock at night, I would maybe go into 10 different patients' rooms, wearing this for a minimum of 10 minutes when I went in there. What happens is you go into a negative pressure room because the air in these patients' room is the bad air is being sucked out while the good clean air is being ventilated in. It's kind of like being on an airplane. They circulate the air. Okay, that's okay if you're wearing one of these because you're getting that fresh air. But if you're not, if you're wearing one of these and just walking around, you're not going to be breathing very well. Just want you to know that. Also, it's not only the air that's you're trying to breathe through, but the carbon dioxide inside the mask is not being let out. So you're breathing more of your own CO2, which is not a good thing because the higher your CO2 level gets in your blood, the more lethargic you get. I heard that word from one of these moms. Okay? And it was, you get lethargic when your CO2 gets high. Okay. Also, you get headaches. I invariably had a headache after wearing this 3 hours, even though I had it off in between every room. You can get headaches because you're not breathing correctly. Okay, second thing is healthcare workers are being treated unfairly. Oh, I'm way over time. I'm going to try to do this as quick as I can.
Thank you.
I had a dear friend of mine who passed away. She was in her 50s. She had been a respiratory therapist for over 25 years. The day after Christmas, she stopped breathing. The only thing they can come up with is that she probably had a cardiac arrest. Okay, we have been hearing that there have been many adverse reactions to these vaccines. A lot of them are blood-related. Yes, and also a couple other things I'd like to just point out. Senator Ron Johnson had a medical experts discussion pandemic response. There's 4 doctors who speak. If you want to look this up online, they said a lot of very important things about vaccines being corruptions. Doctors are being forced to put profits in front of patients. We all hear about Pfizer, the billions of dollars they're making. Also, one unknown doctor was called in for a pure sham review. He had 7 patients in the hospital, but because he was treating them the way that he felt he wanted to treat them, with the hydroxychloroquine, with the remdesivir, whatever the meds he wanted to do, with the therapeutics in the hospital, his privileges were taken away and he was kicked off the medical staff. I have many other things here about severe reactions to COVID vaccines. You can find this on burningplatform.com. Many national polling of choline vaccines shows that there's 5.2% in all groups that have been severe adverse reactions. I personally believe that my friend died of a severe adverse reactions to the booster shot that she was forced to get as a healthcare worker since the Supreme Court ruling that that they're starting to drop. That businesses with over 100 people do not need, they block the mandate, but healthcare workers have not been blocked, and they're pushing the healthcare workers to have boosters and such as this, and it was shortly after this time that she was found unresponsive. So things are happening, and I'm sorry to say that I know somebody who I lost who had at least 30 years as a very skilled respiratory therapist who is no longer able to bless other people with her experience. Thank you very much.
Thank you, Jan. And we're sorry for your loss here. Next up, I have Kent. Kent Higgins. Kent, good morning. How are you?
Good morning. Good morning to everyone. Hey, I'm very proud of my wife. Very good. Okay, when the COVID vaccines were first rolled out, here is what the media told us. CNN's Jay Reimer, being vaccinated prevents you from acquiring severe illness, but we know with certainty that it largely prevents transmission. March 3rd, 2021. Okay, we also just recently, as you probably know, by the way, the CDC just came out only after 2 years they finally admitted this, stating that natural immunity is stronger than the vaccines. 2 years. Any first-year med student knows this, and I'm ashamed that our public health officials do not even mention it. Here's some more information from the CDC and the New England Journal of Medicine. The head of CDC finally admits PCR tests aren't reliable. According to CDC's Rochelle Walensky, PCR tests often produce a large amount of false positives. So the PCR tests were relied on for deaths in the hospital. How many deaths in the hospital? We relied on this test. 10-day quarantines for everybody that was tested. Closing businesses worldwide. The test was fake, phony, and false. If you had the flu or a cold, you were positive. How often does that happen? CDC admits PCR tests are a fraud. So what about the 2 years? What about that? That's what I'm asking. Why 2 years later? New England Journal of Medicine, masks are ineffective. The Lancet acknowledges that the efficacy of the COVID vaccine is around 1%. That's how good it is. A peer-reviewed study of the prestigious scientific journal, The Lancet, confirms that the efficacy of the vaccine is not 95%, as claimed by the vaccine companies, but remains at 1.3% for AstraZeneca, 1.2% for Janssen, 0.84% for Pfizer, and 1.2% for Moderna. They all misled by reporting relative risk reduction. In other words, they just kind of made up their stuff here instead of an absolute risk reduction. They just kind of just threw this out. And then if you really look into it, they just made up stuff. Israel study shows natural immunity 13% more effective than the vaccines at stopping Delta. There's a similar Harvard study that says about the same thing. I think we know this already, or hopefully we do. Vaccine rates are not linked to lower COVID rates. Epidemiology paper finds. A new paper in the European Journal of Epidemiology that analyzed 168 countries. This is a big study. Analyzed 168 countries and 2,947 U.S. counties, found that the higher vaccination rates were not associated with fewer COVID cases. October 15th, 2021. Okay, this came out a couple of months ago. The Red Cross can't take the convalescent plasma from the vaccinated people. The vaccination wipes out most antibodies. So if your antibodies are low or gone, how do you defend yourself against the disease? The FDA just asked the court to allow Pfizer to keep all of their information hidden until 2076. So the Federal Drug Administration asked the federal judge to give it until the year 2076 to fully release the documents in its possession. Documents tied to the approval of the Pfizer vaccines. Why is this? This should tell you everything you need to know. They don't want us to know what's in the vaccine. Can I keep going?
We've got a bunch of other people who want to go. If you could just kind of summarize.
Okay, I'll just give you another minute or so. Is that okay?
We'll give you another minute. I'm sorry, just
Okay.
because we have other people that want to speak.
Okay, I hear you. Okay, I'll just go to this real quick.
Okay.
I had a lot more. I guess I could have bored you some more, I guess, but
and you can always.
I have a lot more. Can I come up and get?
No, not this meeting, but next one. Yeah.
In conclusion, if you have to be persuaded, reminded, pressured, lied to, coerced, bullied, threatened, punished, and criminalized, if all this is considered necessary to gain your compliance, you can be sure, absolutely certain, that what is being promoted is not in your best interest. I appreciate the First Amendment. Thank you.
Thanks, Kent. Okay. Next up, we have Charles Chetron. Is that right? Am I saying that right? Charles, good morning. How are you?
Good morning. How are you?
I'm good, thank you. Did I say that right? Chetron?
Yes, very good.
Yes,
very
thank
good. Anyway, I'm just going to go over a couple items here. I won't take too much of your time. I'd like to bring to your attention the Epoch Times in their January 5th to 11th edition they had an article that pointed out on October 4th, 2020, that we had the Great Barrington Declaration. Now that, in part, was put together by 50,000 scientists and medical professionals and more than 800,000 members of the public. And they came up with the following statement. Contrary to prevailing narratives, there was no scientific consensus in favor of lockdowns. Now, I assume you all know that yesterday in Washington, D.C., there was tens of thousands of people that appeared before the Capitol with the same statement. Tens of thousands of our people. Okay. One other item, and then I'll leave. But as of this morning, in the U.S., since the inception of this terrible thing, 862,000 Americans have died supposedly with COVID. This is according to the CDC. In relationship to the population of the United States at 360 million people, that works out to be 0.002%. And with that, I'll give up my time. Thank you very much.
Thank you, Charles. Okay, next up, we have Maddie Short. Maddie, good morning. I might have two cards for you here.
Yeah, one
Okay.
of them, yeah.
Perfect. All right.
I really do see our constitutional rights being stepped on. When America was first formed, our founding fathers wrote the Declaration of Independence, and it states, "We hold the truth to be self-evident, that all men are created equal by their Creator with certain unalienable rights." Yes, making a vaccine mandatory makes us all equal, but not in the way our founding fathers, nor in the way God intended. Genesis 1:27 states, "So God created man in his own image. In the image of God he created him. Male and female he created them." God did not create us all to be the same. However, he created us each uniquely and intimately. We all have the same rights as human beings, but each individual is different. Psalm 139:13 quotes, "For you formed my inward parts. You knitted me together in my mother's womb." These rights given to us by God are the rights of liberty, life, and the pursuit of happiness. Forcibly mandating a vaccine takes away this fundamental right of liberty, life, the pursuit of happiness. If we don't have bodily autonomy, we are no more than slaves to the people we, the citizens, hold authority over. The United States government, of the people, by the people, and for the people, shall not perish from the earth, as the great Abraham Lincoln once said. If America chooses to force unwanted medical procedures on its citizens, we will indeed perish as a nation. We are the only nation built on individual freedom and God-given rights. When these rights are stripped, we replace God with the government. And as history has proved, that has only ended in destruction and misery. Thank you.
Thank you, Maddie. Thank you for coming down. Okay, Yvonne Reynolds. Yvonne, good morning. How are you?
Good morning. How are you?
Good,
It was
thank
nice
you.
to meet you in person, actually.
Thank you. Nice to meet you too in person.
I started sharing last time, and I wrote more than my time, so I thought I would just kind of pick up from where I was last time. So an article in the Washington Examiner, this was actually a couple weeks ago now, is advising that we take El Salvador's coronavirus advice. Their president shared a video last week about a new ad campaign to help prevent COVID-19 deaths and hospitalizations. The article states, "For once the campaign about a public health crisis focuses on health itself. Live a healthy lifestyle, eat a healthy diet, lose weight, get fresh air and exercise. To be outside to improve your vitamin D levels, get vitamin C from fruits and juices, drink water to keep kidneys healthy, reduce stress, get a good number of hours of sleep, avoid alcohol and fatty and sugary foods. What a concept. Could our fast food, microwave, instant gratification, couch potato society have anything to do with the high number of deaths and cases of COVID-19? I don't have a medical degree, but my answer would be yes. Actually, if you look at some of the studies that they've done of South Africa, they are currently in their summer. So they are getting large amounts of vitamin D, and they have ivermectin available over the counter. They don't have to have a prescription for it. They don't have to go to a veterinarian for it. It has been widely available for years. So it is past time to change the narrative. Instead of scaring people and causing them to live in fear, we need to return to a sense of normalcy in our county, in our state, and in our country. Instead of focusing on cases and positive tests, we need to educate people on how to be healthy and encourage them to live their lives to the fullest while they are still alive. Instead of continuing to abuse our children, we need to allow them to function normally in society and to get rid of all the masks that was just decided in the state of New York by court. Are you familiar with the story of Daniel in the Bible? When the king established a statute to enforce an injunction on anyone who made a petition to any god or man beside the king, they were to be thrown into a lion's den. From Daniel 6:10, when Daniel knew that the document was signed, he entered his house. Now in his roof chamber, he had windows open toward Jerusalem, and he continued to kneel on his knees 3 times a day, praying and giving thanks before his God as he had been doing previously. Daniel did not obey the ruling authority. He obeyed God, and God saved him from that lion's den. I am called to obey God, especially when the ruling authorities are making irrational decisions that affect our constitutional freedoms. Back in 1999, my husband and I made a decision to follow Jesus Christ. We also began a journey to homeschool our children. And at the very beginning of our journey, I started reading about what is going on in the educational system in our country. This book, called Dumbing Us Down, was written by a man whose name is John Taylor Gatto. He was named the Teacher of the Year in New York numerous times. In this book, he says, the truth is that schools don't really teach anything except how to obey orders. You can see what is going on in our country, how easily people have followed orders given by Dr. Fauci, by President Biden, by Gavin Newsom, by many other people in our society. It also states in here, schools were designed to be instruments for the scientific management of a mass population. Schools are intended to produce, through the application of formulas, formulatic human beings whose behavior can be predicted and controlled. I know when I first came and spoke the very first time here, I talked about Nazi Germany. Our public schools are doing this to our society. Our social media is doing this to our society. The mass media is doing this to our society. The politicians are doing this to our society. And I appreciate that all of you are listening to us and considering the things that we have to say. Thank you so much.
Thanks, Yvonne. Okay, next up we have Madeline Baker. Chance, I'm gonna let you come here while I run to the bathroom really quick here. Maddie, I'm gonna run to the bathroom really quick, but I'm gonna let Chance, sorry.
Okay, you're fine.
Do this, I apologize, but
Thank you, sweetheart. Here, look. There you go, crackers.
be right back.
Gosh, Terry.
I'm sorry, Maddie.
How's it feel sitting in the big man's chair?
First time.
Look at you.
Oh, thank you.
Sorry, guys.
Good to see you, Madeline.
Good to see you. I'm Madeline Baker. This is my son, Maverick. He wanted to go to work with me today, so we'll see how this goes. I wanted to
Public Health had made a comment about how they were reaching out to the medical offices in our community. So I text some of my girlfriends and friends that are in both private and public practice, and the overwhelming majority of them had not received anything from Public Health. So just in the future, if they send out things moving forward to make sure that it is all inclusive of multiple providers. I'm not sure if it just, goes to like Golden Valley or what offices, but just maybe in the future moving forward, make it a more inclusive list. I had notes, I don't know where they went. So I was watching a video the other day that a community member, not in our community, oh, thanks, team effort. Had said that, our children no longer need to be our children. They need to be the community. And the community did not birth my child. I went through 27 hours of labor with this beautiful boy. And, as Americans, regardless of what our medical decisions are, it should be our choice. If I decide to vaccinate Maverick, with the COVID-19 vaccine when he's 5 years old, weighing the risks and the benefits and his comorbidities as his mother and his parents, along with, I'm a provider, so under that info, but along with his healthcare provider, that's a decision that everyone should be able to make. We see that in, like someone else had mentioned that in New York, the courts just ruled to not mask, and I do believe in mask choice. Because what works for me and my family, I don't know everybody's comorbidities. I don't know what, health things other children have. But in regards to vaccinating, making it a requirement, again, it should be choice. And that's what I have to. I also thank law enforcement. And that's our spiel today, guys. Thank you.
Thank you, Maddie. I'm sorry I couldn't wait there, but thank you, Maddie. Okay, next up we have Adam Corkin. Adam, good morning. How are you?
Good morning. I'm well. Good morning, Honorable Supervisors. I wanted to talk to you today about the importance of blood donations and other things we can be doing to promote the health of our community. So earlier this month, I donated blood. I had Power Red. It was a double pint equivalent. I'm not a healthcare worker, and during this crisis, one way I could serve the medically needy would be to be more consistent in my blood donations, something I've done since my 17th birthday. And as I prepared for my appointment, I thought about how many lives could be saved if more people would donate blood, get typed for bone marrow donations, and register to donate their organs in death. According to the American Red Cross, every pint of blood saves 3 lives and benefits patients with trauma, sickle cell anemia, burns, cancer, organ failure, and surgery. Yet even pre-COVID, only 3% of Americans gave blood. Many will brag about how they've taken a jab for their community, yet we are facing the first nationwide blood shortage according to the American Red Cross. I hope each of you will consider how you can use your influence to promote this vital opportunity to serve. All these activities require informed consent, and so far none are contingent on a COVID jab. I have found the actions of our government chilling in the way that we are othering the unvaccinated for a small gain in herd immunity. Some jurisdictions are excluding the unvaccinated from a substantial portion of the economy, including healthcare, federal contractors, and certain workplaces. Public accommodations like restaurants, hotels, and shops. Receiving a donated organ. Excluding children from public schools, excluding people from visiting their dying relatives and attending medical visits with their children. And in some places, international travel. In December, Dr. Fauci recommended we start excluding the unvaccinated from domestic air travel. Those with 2 shots are now obligated to get a 3rd, and as many as are recommended to maintain access to public life in many jurisdictions. These tactics are expected to yield about a 5 to 8% increase in herd immunity and a small theoretical gain in public health, yet at a tremendous cost in human dignity. Coercion and othering is a long-term harm in our community. It manifests itself in depression, hopelessness, isolation, homelessness, drug addiction, and many self-harms, and increases in criminal activity. Many never recover from the trauma. Dignity is vital to the health of our community. 3 lives are saved for every blood donation, 7 lives saved for every organ donor, more who experience quality of life improvements like restored vision through these generous donations. There are certainly a lot of gains for our community, but we need informed consent, and we need to protect human dignity. We need our community to restrain from shaming the reluctant. I've taken many jabs for my community to give blood, but the only one that seems to matter is a COVID jab. Second topic, transitioning from that, the latest data from the UK, Canada, and now the CDC, sourced from Kaiser's Southern California hospitals, show that natural immunity from recovery offers superior protection than 2 shots for the uninfected. Natural immunity is real and offers superior protection against transmission versus the mRNA platform. This is not a recommendation to go get the infection, but we need to acknowledge that over 160 million Americans already have natural immunity. Yet the CDC continues to downplay the role of natural immunity and how it can play in people optimizing their medical decisions about their health and those around them. I am COVID recovered, yet the federal executive order stands. If it stands, I will be required to take 3 shots in order to keep my job. Our healthcare workers are facing a similar requirement. That is not a good recommendation medically. Healthcare workers will leave their jobs, and while incentives may help move staff from one area to another, the supply of healthcare workers is not easily fixed in the short term. It takes 6 years to become a nurse, many more years to become a doctor. That's not something you fix short term. If we understand the risk stratification, different factors result in different risks for different segments of the population. We recognize that our children were never really facing the same risks as those over 65. When the mRNA jabs were rolled out, we did not know about the myocarditis risk. We now know that it's a greater risk for young men and boys under 40 than catching COVID. Several well-respected doctors suggest that recommendations should change. It's not just all or none. It could be less shots, more spacing, alternate dosages. As a father of 3 sons who are also COVID recovered, myocarditis is a real risk. Studies out there show that for Moderna, the risk is 1 in 3,000 that they will encounter myocarditis. Across 3 doses for my naturally immune son, it means my household faces a 1 in 333 risk of myocarditis. We won't be getting Moderna, but there's still significant risk from the other mRNA COVID jabs. The risk significance for the broader population will be less, but I have to make a decision for my household. It's enough of a risk that across Europe, many health authorities are no longer recommending Moderna for men under 40. Yet if the state passes new legislation, 3 shots for young boys will become a requirement for school, a risk that does not offer a superior benefit to their health. We need to learn more. Coercion is not a tool of capable leaders. Medical decisions are rightfully the domain of the individual and family, made in consultation with their medical caregivers. Medical professionals need to be free to offer data-driven advice and not be messaging vehicles for a politicized public health narrative. It is time to abandon mandates and respect the individual. Use influence and education, not coercion. Let's commit ourselves anew to human dignity. Thank you so much.
Thank you, Adam. Okay, next up we have Aaron Noriega. Aaron, good morning. How are you?
Good morning, sir. Thank you all for your service. Thank you for the time here today. Before I forget, because my phone died, I just wanted to share something somebody asked me to share. It's a little disappointing that the public health officials have left and aren't here to hear some of the stuff that is being discussed.
We still do have Mary Ann over here.
Okay,
Mary
good.
Ann, yeah.
Good. So the Emmanuel Medical CEO stated that 60% of emergency visits are COVID related. We know that preventative care and early intervention reduce severe illness by 85%. Why is public health not educating the public and making early intervention accessible to us? So I just wanted to further on state that I work in law enforcement. I don't work in this county, I live in this county. And you have people putting their lives on the line every day, healthcare workers, prior to vaccination being available, and they did their jobs. As a result of that, you have over 160 million Americans that have natural immunity. Now, the Omicron variant has proven that it can evade both vaccination and natural immunity. However, it is less severe. The data from the UK is showing that, as well as the data that continues to roll in here. So we proceeded in a manner where we're mandating things on the population based on data, okay? So if we think back to how this all started, PCR tests were used for case rates and then hospitalization. Well, the CDC decided that they were going to revoke the use of the PCR tests. There's already data out there that they create a ton of false positives. The cycle rate is very significant in creating a positive test. And they've also admitted that it actually doesn't determine whether that's a virus that becomes transmissible to someone else. Yet, we're still using positive tests as a reason for a policy to move forward with mandates such as vaccination and masking and social distancing and those things. We've done that for 2 years, and we're still in the same boat. Why are we still doing the same things that haven't worked over the last 2 years? I also want to talk about asymptomatic transmission. That was also a big thing. That's why we were testing everybody. Dr. Fauci, and I can send this to any of you guys, spoke back in early 2000s, and he stated that asymptomatic transmission is never the driver of a pandemic. Never. Those are Dr. Fauci's words, not mine. Yet, we're treating asymptomatic people as if they're carrying a disease that's going to kill somebody. That's not true. It's never been accurate. It's never been something that has been science-based. Even one of the ladies from the WHO, I don't remember her name, she admitted the same thing as well. So I just wanted to bring that point. I also wanted to talk about prophylactics and preventative measures. Why are Western worlds not allowing access to FDA-approved drugs, such as ivermectin and hydroxychloroquine, that are proven to be effective against COVID? Again, if we treat it early, you can reduce hospitalization, you can reduce death. You have states, you have other countries like Qatar in India. There's an awesome study that came out. Their population is 241 million people, pretty close to the United States. They have like a 20-some% vaccination rate, and they're kicking COVID's butt. But they make ivermectin available to their people. They're giving it away. El Salvador is giving away ivermectin. They have a pack that they give away. It's ivermectin, zinc, vitamin C, vitamin D, and some other stuff. They're giving that away to their people, and they don't have the same type of issues with COVID that we do here in the United States. So I just want to bring those things to light. I think it's not talked about enough. This whole idea of the only way out is through vaccination is, to me, ridiculous. We had more people die when we had the vaccines than when we didn't. People are still getting sick. COVID is obviously not going to go away. And to try to force a vaccine on somebody, that there is no long-term data, I don't care what anybody says, this was produced in 10 months. That's not long-term. Okay? Long-term data, traditional vaccines take years before they're proven to be effective and safe and have the benefits outweigh the risk. So as a resident of this county, I'm actually proud of this county because I think this county has kind of bucked the standard that some of the other bigger counties, like the county I work in, but it just boggles my mind. And it's because of things like this that someone like myself, other people I know, are going to leave this state. They're going to leave the state of California because they don't have freedom. They don't have the options to make medical decisions for themselves. So I think it's important that we recognize that people should have the ability to choose, and if they choose not to be vaccinated, that they're not treated like lepers and as if they don't belong in society. So thank you for the time.
Thank you, Aaron, for coming down. Thank you. Okay, the last speaker card I have is Candace, and I am not going to try that. I'm sorry.
Don't. It's hard. Hello, my name is Candace Wyrock. I've never been here before, so this is my first time.
Now I'm curious. Now I want to know what your last name is.
Okay, it's Wyrock, but it's spelled crazy. It's Wyhrauch. So, what were you gonna guess?
No, I was going to say Wyrock.
Oh, of course. A lot of my friends just spell it the way it sounds so that they remember how to say it. Anyways, so it's nice to meet you guys. No, that's okay. It's a really I could tell. As soon as he said Candace, I could see he was like, oh no, I don't want to say the last name. But it's nice to meet you guys. First of all, I'm very impressed with what I've seen today. Like I said, it's my first time coming here, so I'm super impressed with all of you. Chance Conda is my supervisor, so nice to officially meet you. I've been impressed with what I've seen with you doing, with the stuff you've been doing in Patterson. I'm thankful that, you actually asked questions and kind of pushed back on some things today. So I'll get right into it. See. So, also I'm impressed with all the people here today that like stood up and used their voice. Like, is this normal? This is great. I'm really impressed. So good job, you guys. I'm proud of you. All right, so I just wanted to let you guys know that I'm here asking that we end the state of emergency. Yeah, I think that's why a lot of us are here. So I've recently been attending all of the Patterson Joint Unified School District board meetings and Patterson City Council meetings since November, because we're currently dealing with an issue with our a high school math teacher who just so happens to be our mayor, having an inappropriate relationship with minors. And he was actually Snapchatting inappropriately a student on his personal Snapchat. So if you're curious about, those of you in the audience or up there, if you're curious about specifics about it, you can Google Dennis McCord and like 15 articles will come up from CBS Sacramento, the Modesto Bee, Patterson Irrigator. We've several community members, and when I say several, I mean like hundreds, are now asking him to resign. He hasn't resigned, so we're moving forward with a recall. But because I've been attending all these meetings since November, there's been a repeating trend that these elected officials, both elected at the board and elected at the city council, have been using these crazy generalizations and extreme statistics, but not actual statistics, like just throwing out generalizations about COVID and how it's affecting our community and using that as fact and pushing fear. And they have zero proof or science to back it up. At the most recent board meeting, a superintendent said that the hospitals are full of young people, and implied that it was them dying of COVID, which was baffling to me sitting in the audience. And they won't look us in the face right now. They're currently in a separate room and we have to watch it on a TV. So I appreciate that I'm getting to look you guys in the face. It's a lot easier to talk to you when I can make eye contact with you. And then the city manager and our council has also echoed similar sentiments, stating that hospitals are full. So I felt like it was my responsibility to come here as your constituent and a member of this community to inform you the truth that what's actually happening in our county. I have a friend who's a paramedic in Modesto. So he doesn't work in the hospitals, but he goes into all of the hospitals in Stanislaus County, and he sees all the victim or the patients that he's transporting from certain situations. And I picked his brain once I heard this at the last city council meeting and the last board meeting. I said, tell me the truth, like be honest, even if it's what I don't want to hear, because I need to know that what I'm being pushed and told and what our community is being told, I need to know if it's true. And so he said, I can tell you that both the ERs that are filling up, it's both vaccinated and unvaccinated. He hasn't seen at all a difference in vaccinated versus unvaccinated. And most COVID-specific calls are very minor flu-like symptoms right now, which I think is a blessing. I think we're seeing a little bit of a turn here. There are more critical patients that may also happen to have COVID, but COVID is not why they are going to the hospital. There's increased wait times for ambulances to get to patients and get them in beds, but it's not COVID that's causing that. This is just a busy season. The COVID cleanup protocols also take super long. So if it's a cold or flu patient that they're transporting, they don't have to do anything special. They just clean the ambulance as normal. But if it's a COVID patient, they have to take extra precautions to really clean it, and it takes a long time, which increases the wait times. So I see that I'm running out of time, so I'm going to try to speed this up. But also, everyone knows that on Christmas, your kids get new toys, right? And then they break a limb. So something that he's seen is that kids are going in for really bad breaks, and if they test positive for COVID, they're counting that as COVID. So when the superintendent's telling me that our hospitals are full of children, it's not from COVID. So real fast, I'm just going to be real short. I just want to state that to make things personal. So my husband was put on the virus response team in a neighboring county in April of 2020. He was exposed every day for work, and our family managed to avoid catching COVID until January of 2022. We literally just recovered from it a couple weeks ago. And he actually caught COVID from his fully vaccinated office. And if I had not tested, I wouldn't have even known that I had it. My 2 daughters never tested positive the entire 2 to 3 week period in which my husband and I were positive. My kids are pretty healthy, but my 3-year-old definitely just ate a bag of Cheetos during this meeting. So like, you know, take that with a grain of salt. But I just want to say that, you know, God created our children's bodies magnificently, and He created our bodies magnificently. And I don't think that extending a state of emergency and keeping my kids away from their friends and keeping businesses closed is the answer to the problem that we're facing. So I just want to thank you guys.
Thank you, Candace, for coming. Thank you. Okay, that's all the speaker cards I have, but you guys already know the drill. So thank you.
Thank you.
Come on up.
Hello, Corinne Whitlow. I am just here. I would also like to speak on the local state of emergency. I would like that, I very much so like that you guys have recognized that we are no longer in an emergent state. I'd like to talk a little bit about the resolution which declared our local state of emergency here in Stanislaus County. It was declared March 17th of 2020. In the discussion, it stated in particular the virus is considered serious by public health threat as much is still unknown. So the local state of emergency was ratified on a state of much being unknown. We are 2 years into this. We know a lot more. We may not be utilizing everything we know, but I think that's because we still fall under these state of emergency type policies. In my opinion, according to what the CEO from Memorial was saying, he was saying we are almost at a disaster level in the hospital. My opinion is because we are following these protocols which are allowed to be implemented because of these state of emergencies, we are following the guidelines of the CDPH and the federal government. 2 years of doing that, we are in almost a disaster mode. It doesn't seem like 2 years into this, by following the state and federal guidelines, that we should be close to a disaster mode. My theory is it's self-inflicted. I work in an acute care hospital in this area. I will tell you that we are seeing a rise in COVID cases, but the impact in the hospital right now is not because of the patients. The impact in the hospital now is because we have spent no efforts in our healthcare infrastructure and the people within it. We talk time and time again, we need to implement these mandates because of our straining healthcare system. When have we seen an update of what we're doing for our healthcare system? How many healthcare employees have been fired since we've implemented the mandate to help the straining healthcare system? How many have retired? How many are not working in acute care hospitals anymore? I'm telling you right now, our staffing, the amount of staff we have available in a hospital is nowhere near where it was when we started this pandemic. When we started this pandemic, I was furloughed. I'm a shift manager. I was furloughed because my unit was shut down. We stopped all surgeries. We stopped everything, right? We didn't need staff because we had no patients. Everybody was sick. Everybody stayed home. We popped up tents in the front of the hospital to take care of all these COVID patients. They didn't come. But we did it. You know, we locked down our hospital. We stopped surgeries. We did everything. Then the COVID came. Then CDC started making recommendations based on availability, not on science. We wore foot booties on our head. We bought our own masks online. I bought KN95s for all my staff because they were not allowed to wear N95s if they weren't taking care of COVID patients, and they were scared. I personally bought them off Amazon to give to my staff. Where's public health when it comes to our straining healthcare system? Have you guys heard of anything they've done for our straining healthcare system? We have update after update. Our mandate literally says because of straining healthcare systems, we have to implement these policies. Have you seen anything they've done for our structure? I'm telling you right now, they're hurting our healthcare infrastructure. The people inside healthcare don't want to go to work anymore. We don't like what we're doing. You know what? I'm not going to call it healthcare anymore. We're going to call it medical care. We are not making people healthy right now. We are not making people healthy. We are not taking care of the protectors in our hospital. So I personally think by ending the local state of emergency, we are communicating to these people who are guiding us in these protocols, and we are leading the way here in California. I am so thankful for you guys. I look around at other counties and what's going on, and I'm so thankful to live here. So thankful to be represented by you guys. I think this is our opportunity in Stanislaus County. Now, ending the local state of emergency is not just a resolution, right?
I don't by any means want it to seem like we are not in a critical state. COVID, in my opinion, is worse now than it was before because we are so blinded to the reality of it. We are not treating it appropriately. We are not treating our community appropriately. So I'm just asking you, let's end this local state of emergency and let's start the real work of taking care of our community in Stanislaus County and not following what the recommendations of CDPH and the federal government are. Clearly, they don't have our best, our public health out, or maybe they just don't know what our public needs. We do. We need to take control.
Thank you, Corinne. Good morning.
Good morning. My name is Elizabeth Steingrave. And I was just coming, I just wanted to ask, Manny, I'm in your district, and I wanted to ask, what is the plan, like kind of similar to what Chance was saying, you know, what is the long-term plan? Do we have anything set where it says, okay, here are the guidelines for removing the masks from the school, or even, you know, potentially in the future, the vaccine mandates of, you know, a certain percentage of pediatric deaths or pediatric hospitalizations, and basing our decision on those rates. Because right now, and we just had you know, everyone went back to school after winter break, and there was a big surge at the schools. My kids had half their class missing. Everybody went home, everybody quarantined, did their thing, they're back. The kids are back, and guess what? They were wearing masks the whole time during the mask mandate. Everybody still seemed to get it, and everybody still seemed to return. None of my children's classmates ended up in the hospital. You know, none of them ended up with death. So I'm just wondering what our plan is here moving forward. And I'm with Sylvan School District, and so I'm just asking you if you could just look into that and see what is the criteria, and maybe if we can move forward once we know those kinds of answers. Thank you.
Good. I think Jody's, Elizabeth, I think Jody's going to just really quick.
Oh, yeah, that's okay. For the last speaker, or for many of those folks who have spoken today, just a couple of thoughts on some of the theme about, you know, what comes next and so forth. For those of you who were able to, I think 2 weeks ago, we did provide kind of an introduction to some of our thinking about what we can do here at the local level in this year in the wake of Omicron, and the recognition that that as this virus has adapted over the last year, we have to adapt with it, and that it seems like a lot of policy issues are not adapting as quickly as the virus is adapting. Basically, that's generally what we were trying to acknowledge in the comments a couple of weeks ago, but also a recognition that we want to be very intentional about what our local emergency response is to COVID-19 in Stanislaus County. So we'll be doing that on February 8th. We'll bring that back, and I would encourage you to try to pay attention to that. But what you're going to hear is, and I want to acknowledge that I think the vast majority of the feedback and frustration that we hear in many of our meetings are not policies that you're going to see that are emanating at this local level. These policies were not initiated in Stanislaus County by anybody who works on our emergency response, and there are other certainly government agencies. I know it's oftentimes just referenced at the state and federal level is where you're seeing a lot of these frustrations. So I just want to acknowledge that, yes, we'll be back here, we'll talk about a lot of these things, but we have to be focused, our team, locally, and that's where we're going to stay focused, is what can we do locally given whatever's happening in the state or federal level, at the staff level. And I know there'll be a variety of additional opinions, some of which may come from board members. But at the staff level, I think what you can expect is just a concentration on what can we control locally, what can we do given what we know, and a commitment of our need to evolve as the virus evolves. Thank you.
Thanks, Jody. Okay.
Hey, how's it going?
Good, how are you?
My name is Richard McGee. This is my first time here. I'm not in Stanislaus County, but I'm here to support my fellow warriors here. And also, I work in law enforcement, and I'm going to play bad cop, okay? That's my partner over there. We come from a county of... Is that? Oh, there it is. Oh, I can hear me. So I'm going to play bad cop. So I'm just going to say that people are following the money. None of these people here, they're not stupid. They have hit more than enough facts. They actually debunked that public, whatever they want to call themselves. They debunked the living crap out of them. They really did. I watched every single one of your guys' expressions. Like I said, I've been around killers, murderers, rapists, all of it. We're following the money. This county has the opportunity to lead by example, not by what you're saying, but by your actions. By your actions. What you need to be doing is rallying with the people who are getting the facts and debunking the living crap out of your public health office. Because guess what? We know they got paid, the government gave them a certain amount of money, and for them to meet that quota and get the rest of that money, they're pushing to people get vaccinated and wear these masks on these kids. The United States is not stupid. We the people are not stupid. Okay? We put you guys where you're at. We did. We did. So I would strongly suggest taking what these people, my fellow Americans, took time to research, and again, I can't get over it, debunk the living crap out of your public health people. That's why they're not here, only one of them's here. Okay? You need to stop speaking and take some action. This county has the opportunity to lead the way. I didn't realize how much you guys have the opportunity to lead the way. Okay? The mask, it's all a joke. We all know it's a joke. And now you're putting it on not only my kids, but my fellow Americans' kids. It's got to stop. Because guess what? That accountability is going to come down. And even someone that went along with an unlawful order is going to be held accountable. Just know that. I've only done 5 years with my department, and I figured it out. It's a hustle. We get it. Again, we the people are not stupid. We're not. We're not sheep. I also raise cattle. We're far from cattle or sheep. The mass majority of us are waking up. So I strongly suggest you guys wake up too. Be the example that this state needs. Because guess what? The people will back you. No matter what the federal government says, the people are going to back you. The people. I'm debating about leaving this dang communist state because that's what it is. It's being ran by a tyrant. And people are going along with tyrants. Not for long. Because the truth is coming out. The truth is coming out. So the game, it's got to stop. It's got to stop. You took an oath, I took an oath. Remember that you put the one thing on that oath that we all do, we put our hand on the Bible. And now if you call yourself a believer, I'm not saying I'm perfect, we all have sin in our life, but if you think for 1 second that accountability is going to stop while we're here on God's green earth, think again. We're going to be held even more accountable for the things we've done on earth. And especially, we swore to protect the Constitution, the Bill of Rights, and the Constitution of the state when you put your hand on the Bible. If that doesn't freak you out, like me, I don't know what else to tell you. Wake up. Stop with the crap. Please stop believing these people over here because they're spilling lies and they're getting caught in their own lies. I sat here and just listened to it all. Do the right thing. Take action. Spearhead it. You will have the support of the people if you do the right thing because we're following where the money's going. That's all I got to say.
Thanks, Richard. Okay, anybody else? Come on up.
Hi, good morning.
Good morning, how are you?
I didn't write anything today. The last time I came in, I wrote something, but I'm just going to go off the top of my head.
Just give us your name, please.
Vanessa Santos.
Vanessa, yes.
I just wanted to come here and tell you guys, ask you guys to end the state of emergency. We need a better environment, better community for our kids. I can come up here and talk about the data, but these amazing people did that already. We need a better community for our kids. The masks are not working. I pulled my kids out of school, and the way things are going, I don't see it ending anytime soon. These people are over here educating the health officers here that are here, and I don't know. It's not making sense. Things aren't adding up, and if you guys can please end the mask mandate, I mean, the state of emergency, that way we can get back to our lives and our kids are not going to be treated differently in the future with all this stuff going on. I don't have much to say, but I just wanted to come up here really quick.
Thank you,
Thank
Vanessa.
you.
Thank you for coming up. Okay, anybody else for public comment like to say anything? Seeing none, we will come out of public comment. We're going to head towards our consent calendar. We do have a couple different things here. One, first, thank you all for being here. As we move on here, we have one written comment with regard to C-2 from Dr. Williams Stammer-Johan. And so we're not going to read that, but we have that available if anybody wants to see it. And then also with regard to our consent calendar, we have two items that are going to be pulled, item C2 and item D3. Item D3. C2 and items D3. So besides those items, is there any other item that anybody here on the dais would like to pull from consent calendar? Anybody from the audience? Anything else they want to pull from? Miguel, we've got yours listed there. Anybody else want to pull it? Right, we will. Right, anybody else from the audience? Okay, seeing none, we'll bring it back to the board and look for an action on the consent calendar with the exception of C2 and D3.
Motion to approve.
Second. We have a motion and second. All in favor?
Aye.
Opposed? Passes unanimously. Okay, let's move on to item, we'll start off with C2. Vito.
Thank you very much, Mr. Chair. And so I'm going to go ahead and move this motion when I'm done, but this is for the public, this is a consent for the right-of-way acquisition from the county to the city of Turtle Rock at the corner of Walnut and Taylor. Turtle Rock is proposing to put in a traffic signal. Right now, it's a three-way stop, utilizing mostly congestion mitigation money. And so this happens a few times a year where we cede the power to the city who owns all of the road, but not beyond the road, if that makes sense. So anytime we do public works projects, large ones, North County Corridor would be a good example. You want one jurisdiction, whoever the lead is, or 132 West. Sometimes they have to do condemnations in the county area, so we cede the power, or vice versa. Cities cede the power to the county, whoever the project lead is. And I don't want to stop it. What I wanted to talk about really quickly today is anytime we do it the opposite way, where we're ceding power, we have to remember, because they're going to take land in the county area, and these people aren't represented by the council, so it really falls on us. We represent all the citizens, and I've had conversations with these folks, and they're trying to figure their way through the system because they don't have a direct connection to the Turtle Rock City Council, who will be doing some sort of action. Dave Lehman, our Public Works Director, has had conversations with them. I've talked with them about the process of condemnation or acquisition of their land, whether through agreement. And I don't want to stop the project because, again, I think it's a good project. I just want to make sure that they're represented by us and Public Works Director Lehman, just to make sure. I'm going to call the mayor to make sure that they connect, because they don't feel like their voice is being heard through this process. We've told them to get an appraisal, a separate appraisal. I know that the jurisdiction is forced to pay for that, but I'm just saying that because I just don't think there's been enough discussion with this process. And I know we're talking about this in North County Corridor, and usually start a couple of years before a project happens to make sure that people have a chance to get their appraisal, they have a chance to bring up any concerns, to negotiate without hiring an attorney, hopefully. So anyways, I wanted to bring this up just so that the rest of the board understands my position and Mr. Lehman's position. And I'll continue to try and work through this, because there is an adverse impact. The road will be about 25 feet from their front door. And traffic is going to be going faster. There's going to be some safety concerns. Because a three-way stop, everyone is just decelerating or accelerating. Now they could be going full speed. So I just wanted to say that. I'm going to vote for it, and I will make the motion, but I think it's important that everyone understand that.
Perfect. No, that's a good point. So you're looking out for these people is the bottom line there.
I'm trying.
To make sure this works. Very good.
I'll second the motion.
Okay, we have a motion and a second. All in favor?
Aye.
Opposed? Passes unanimously. Very good. Okay, we're going to move on to item D3. And we do have a speaker card for this. Item D3 is approval of the technical amendment to the award of the second release of a California Emergency Solutions Grants Coronavirus Aid Relief and Economic Stimulus Act Round 2 funding for street outreach and engagement services, and to negotiate and execute an amendment to an agreement with Turning Point Community Program, Inc., Garden Gate Respite, to provide street outreach and engagement services. That is the item, and we have a speaker card here from Miguel Donoso. Miguel, thank you for waiting this out. Sorry it took so long, and come on up.
Thank you, Mr. Chairman.
Good to see you. How are you?
Nice to see you, sir. Mr. Chairman, we have two plans for these programs. One was in June 29, 2021, and the other was in today's meetings, 1/25/22. The question is, what is the difference in these two plans? To me, the difference is what? The Housing Homeless Division make a mistake and not to reach the community members and the nonprofit agency for the street outreach funds to implement the street outreach in the minorities and low-income families or homeless community. Mr. Chairman, the CSA under the Housing Homeless Division, today we're going to lose more than over $2 million. You approve the program. Because of the Housing Homeless Division, that's the problem. Mr. Chairman, if this project is approved, what guarantee had the behavior, health, and service and the probation department that we work with the community members and groups or nonprofit agencies to guarantee a better street outreach and engagement, especially in the racial equity and the bilingual culture, policies and programs that was regulated or is regulated by HUD. I think we need some response, Mr. Chairman. I don't know who's going to respond that, but I think as a member of the board of directors of the system of care, I'm worried that we're going to lose that money. And of course, it's going to be channeled to the probation department and the Department of Mental Health Behavior Programs. So that's not going to be lose the money. But as our board of directors, we are worried, especially myself as a person, as a member of that board, I'm worried what happened to that outreach, street outreach under the Housing and Homeless Division. Somebody make a mistake, and we're going to pay it. So I want somebody from the staff or whoever have the power or knowledge to respond for that. Thank you, sir.
Okay, thanks, Miguel. I don't know if we want to address this really quick. Come on up. Yeah, that'd be great. Okay, Mandy, thank you for coming up here.
Good morning.
Morning.
I'm Mandy Sharp, and I'm the director of the Community Services Agency, and we have the Housing and Homeless Division inside the Community Services Agency. And I'd be happy to answer some of the questions. If I took some notes, if you'd like me to address those, or if you have any particular questions you'd like to do in an order.
No, if you just, however you want to do this, go ahead, Mandy.
So first I wanted to just mention that the funding in question is the ESG CV2, and the letters CV relate to COVID. So the funding is specified to be working with programs, in this case for outreach, to my understanding, that involve COVID-related services, COVID resources, referrals. So that funding has some specialties beyond what normal ESG funding is, and it's all around those tens and tens and tens of millions of dollars that have come down into the state. that are for some special purposes around housing and homelessness. And then I also wanted to mention that I've been the director of CSA since mid-September, but my knowledge and understanding of the program specifically mentioned here, the SGCV2, was that the funding in the larger chunk was released over a period of time in a multiple NOFA, RFA kind of process. So the speaker, Mr. Donoso, mentioned June 29th, which is accurate. That's when that decision for ESG CV2 funding to be awarded to the Community Service Agency for the H&H Division, Housing and Homeless Division. That's when we received information, and then, as I mentioned, a couple months later, I joined CSA. The reason I'm setting all of this up is to answer some of the questions to let you understand that the period of time that we have to spend the funding is very short in large program terms. And after I joined the team and we looked at the funds, we worked with our partners here in planning, with the CEO's office, and with individuals with much more experience than I do in the county. We identified that there was a good risk that we may not be able to activate that funding if it were purely activated through the Community Service Agency. There was a fair risk that this funding, in partnership with HUD, these discussions were happening, and HCD at the state level, there was a fair risk that if we not look for existing programs to expand services or define some services to include some of the COVID-related responses, if we don't do that, that the funding might be lost altogether. And that was a risk that was brought to us by the state and federal regulators. That if we don't look for a way to expedite a funding solution for existing partners, that funding could be allocated to other counties or other recipients of similar funding. They did not give us a date, a hard, fast date. They didn't say when it was going to happen or how much was going to happen. So the teams together across the county were activated to find ways to define who would receive these funds as quickly as possible. So there's a really good chance that those funds that we're being asking here today before you to move the funds would have been issued to the same entities. The difference here isn't who would potentially execute the programs for outreach, in this case the Behavioral Health Recovery Services, or probation, not necessarily who would actually execute those services or their subcontractors that are listed in the resolution. The issue is the expedited way that we can budget the funding by taking it from CSA through Housing and Homeless and direct fund it to these two organizations, Behavioral Health Services through their contractor and probation. And rather than having it reside within the CSA budget, it's going to be more expeditious to have those funds directed to those different departments in the county. So it isn't, yes, it's a loss to my division and Housing and Homeless and my department in having that funding reside within my department, but it's a gain to the county because we're going to be able to execute the programs that are intended to be run by this ESG CV2 with partners that have the ability to do that, and we're going to be able to have that funding reside within those departments, which is going to be a faster form of, it's just a faster form of having it budgeted. We did this in discussion with our federal and state partners, our local community, county partnerships with planning and others, and decided that this would be the fastest way to ensure that those budgets would be recognized by the funder and that they'd be accepted by the funder and that that funding would not be at risk to lose. So while it is a loss of funding directly in my department, it isn't a loss of funding in the county, and it's really a technical adjustment of who owns the money to execute the programs. In terms of you know, what happened to street outreach, this is street outreach. These programs are already the street outreach programs, And in terms of questions about who's going to continue to regulate them, the change in where the money sits in the budget in the county, from my understanding, does not change the reporting or expectations, accountability, or outcomes that are expected for the funding. So we'll still have our state and federal regulators watching over us and making sure that that funding is used appropriately and that the outcomes of the outreach teams are realized.
Very good explanation. So to summarize all that, the funds are not leaving the county. They are still here. They were at risk of being lost because of the strings that were attached to it, and CSA wouldn't necessarily be able to meet the criteria with the programs I would think that were within CSA, and they are being still used for similar things. We have multiple departments that do outreach work with homeless, not just through CSA, right? And so these are other departments that are receiving these funds and are going to use them for the purpose that they were intended
Absolutely.
for. And they're not leaving the county.
I'll also say originally, I believe the vision is that CSA Housing and Homeless will have more of a global, centralized role to be able to execute funds like this to partners and organizations, CBOs, nonprofits, county entities. But at this time, it's going to be faster, and we're going to be able to activate the funding rather than building that system and waiting for this money to be used. We want to use the money to show HUD and HCD that we have a way to spend the funding.
Perfect. Jody?
I would like to just add one more element, because I think it's really important to be transparent about expectations and so forth. I think everyone knows that we've received a tremendous amount of funding into the homeless system in a variety of ways. However, all of those funds come with various strings attached to them and so forth. It will not be a shock to us if June 30 comes. These funds are intended to be expended by June 30, and then we have some administrative time to pay bills and all that kind of stuff. But it will not be a shock if by June 30, not every penny of those funds can be spent. That flunks our normal logic test of expectation. We expect that every penny that flows into Stanislaus County can be programmed for the benefit of the community. And in this case, I just want to be transparent. It's going to be very difficult, even with these technical changes, to make sure that we can program every single penny for expenditure in a way that you would expect us. We're obviously not going to go out and waste money in the public just to spend it. So I just want to be transparent about that and say we're doing the best job we can to funnel and to program what is a very, very large amount of funding into this system. Thank you.
Thank you. And then one last thing that I forgot to mention is that the decision was made with, my involvement. Multiple weeks of time, multiple meetings that the director, me, was involved in. So this was not some takeaway that happened to me. This was something our department participated in and preferred as the best way to get the funding out.
Very good. Mandy, thank you very much for that explanation. Miguel, thank you for the question. Hopefully that answers. Sure, go ahead, Miguel.
Mr. Chairman, thank you very much. She's an excellent administrator, no question about it. And I meet her, and she's a beautiful person. But the point I want to make, Mr. Chairman, is we as a member of the board of the continuing care don't receive no information of what is going to happen, especially on the housing and homeless division. I think that's a key element that we're still missing. At the same time, I don't hear that we're supposed to have more racial equity, bilingual, bicultural staff and policies to implement these programs in low-income and minority community. Thank you, sir.
Okay. Thanks, Miguel.
Thank you. Mr. Chair?
Sure.
Can I just, and it really only tags on here with the streets team, the outreach and engagement team. I went out with them one time down in the Turlock area. Kyle De Jesus, who's now in the CEO's office, was in charge, and now it's Raul Dominguez, I think, or CARE. He's with CARE through our department. But the job, the first interaction you have with people that are homeless on the street is typically the outreach and engagement. There's the HEART team, there's the CARE team. So there's different layers doing different things, but trying to get people back with their families is an important component. I know we've had some success down in Turlock recently, and I I just continue to be thankful for the job they're doing because, people need licenses, they need Social Security, and at some point you get so far down you don't know how to get back up. And with the help they're getting from the county, they're putting some people back on their feet. So continue, Mark and Mandy, please tell your folks, again, thank you on our behalf. I continue to be really impressed.
Thanks, Vito. Any other comments? Or very good. Okay, thank you very much for that. Okay, so then we will need to make a motion with regard to item D3.
Motion.
And C, did we already do
I'm sorry, maybe we did. Did we do C2?
Yeah.
We did? Okay.
Okay. Okay, so D3.
Motion on D3?
We have a motion.
Second.
We have a second. All in favor? Aye. Opposed? Passed unanimously. Thank you very much. Okay, let's move on to our discussion item. Item 7.1, approval to partner with Stanislaus County Affordable Housing Corporation and the City of Modesto on a permanent supportive housing project located at 835 California Avenue in Modesto. And it's considered a California Avenue project and the related financing plan, Behavioral Health and Recovery Services. Ruben, good morning still. How are you?
It is good morning still. So.
Okay.
All right. Give me just a second to get my notes organized. All right. So good morning, Chairman Withrow, Board of Supervisors, CEO Hayes, and County Council Bose. And I am here to present actually the first housing project of my time there at BHRS, and I'm here with our Chief Fiscal and Administrative Officer, Cara Aguiano. And we will be presenting, I'll present an overview of the project as well as, and Cara will present some of the more fiscal details of this. So the 835 California Avenue project in Modesto is a recommendation to construct 7 permanent supportive housing units. You'll see there on the map, there is a single-family residence already on the space, and that will provide a 2-bedroom unit. There will be 6 new apartments will be built on the remaining land, and you can see that towards the back of the property. And there will also be a resource center for offices, provision of services, and community activities, and a laundry center. We do have similar models. Of course, you look to the left there on the, or at least my left, you'll see the Courtney Manor project, which has a similar setup there. And it's one of the reasons why we are making this recommendation is this property, we were able to secure that property right next to an existing program. We were able to leverage those resources. This is a new construction project, and as you remember, we've done a variety of projects over the last year. In particular, for instance, Kansas House was a permanent supporting housing project. We took an apartment complex, or a hotel actually, and rehabbed it. We continue to look for other, in addition to new housing projects, we continue to look for opportunities to purchase apartment complexes, hotels, rehab them. You can see in the board agenda item, the cost for new construction has steadily increased over the last year, both in the commercial and private sector as well as public sector. And so we are here with a recommendation for this program, for this site, knowing that we are, making a recommendation for a property that does have high costs because of the current construction market or construction, the cost of construction, inflation materials in our community or in our state right now. But we are also very busy focused on securing existing units and rehabbing them as a mix of services moving forward. Next slide. So the reason why we're here is because in comparison to, I think, previous proposals that the Board of Supervisors has considered, I'd like to draw a very clear point towards that this is a permanent supportive housing project that will serve individuals, BHRS clients that are currently in treatment. So we did an internal point in time count, and we found that about 200, almost 300 individuals within our treatment system of care are experiencing homelessness. So just as you hear the annual point-in-time count done through our homeless continuum of care, where they go out and, you know, find people on the street, and you get that annual count every year, we did a similar count internally. And what we did is we identified the number of clients in our treatment program. So they're open to treatment, they're receiving services, part of our caseloads, and they are experiencing homelessness. So they're living in the street or they're living in a shelter. And so the goal for us as an organization is to begin to increase the number of beds, units. And there'll be a broad mix of those units, just as we've done with a hotel or apartment. We're going to be looking for a broad mix of projects to chip away at that number. And so that's why we're here today. Actually, go back to the previous slide. And additionally, why we're here is because we want to also, as part of this project, just remind the board and our community of the importance of our partners. We, as an organization, Behavioral Health and Recovery Services, don't go out and do these types of housing projects. We do need our partners. And our partners in this project are the Stanco and the City of Modesto, but we have partnered with the Housing Authority in times past. And, you know, they are our partners. We can't do a lot of this, we can't do any of this work without them. And so you're going to hear a concept today about the bridge loan, which speaks to the importance of our partners and how at times we have to, as an organization, partner with them in ways that are very strategic and innovative at times. So I wanted to make sure that there is a clarity about why we're here as well. And the clients, of course, is the focus here, as well as the partnerships that we need to continue to nurture and to build here locally is also important. One last thing before, and you don't have to go back to the slide because I'm talking too much on that one slide. This is not the last of the projects you're going to see this year when it comes to permanent supportive housing or housing for BHRS clients. Myself, along with other directors in the state of California, have been advocating at the state level that with the increase in the homelessness funds that are coming to communities, that we are looking particularly and specifically at individuals with severe mental illness that are on the street, that at times when we're building out housing and shelters within local communities, have trouble accessing those particular programs. So you're going to see in the state level much of their budget recommendations, as well as this last rounds of funds for this fiscal year we're currently in. They're starting to focus on individuals with severe mental illness. And we, as director for our county, I have been advocating at the state level that the funds that are coming for shelter and housing, that when it comes to the populations locally, that we should be prioritizing. I have spoken about the importance that we look at those populations specifically that have severe mental illness and need housing and support services. So this project, we can go to the next slide now, is a supportive housing project. So what that means is for these units will be specifically for behavioral health and recovery services clients that are in treatment. You could potentially see folks coming out of Kansas that have been there for a while, they're ready to move on. We have other transitional housing programs in the county that we have, they'll be moving on from those, and then it frees up space for individuals to come on into those properties. So what supportive housing means is that, you know, these folks are not just, they're on their own, they're open to our treatment teams, they're receiving services. We place them in these units. We've got staff on site, they've got the case managers associated with the treatment programs that are working with them. Lots of supportive programs. We are very proud of our partnership with Stanco and our ability to manage these properties very effectively. I think we've got good reputation in the community with our partners and the neighbors where we have these projects. So Stanco continues to be crucial in terms of our partnership here, and not only in developing these types of projects, but also helping us manage the day-to-day functions of these programs. So the clients in these particular locations are going to have case management services to ensure housing stability. They also have supportive services like peer support, independent living skills, and assistance with the community inclusion. And one of the nice things about this project, it is adjacent to Cortland Manor, Stanco and Beatrice managed property. So this helps us as an organization with outcomes. So what happens is, of those 297 plus people that are currently in treatment, although we are providing treatment, medication, case management, peer support, whatever those services are, moving folks into some type of housing stability helps us improve outcomes for the community. So in addition to taking folks off the street, this also creates some additional units for us to transition folks, maybe from our transitions, from our shelters that are currently in service, getting treatment services into these more permanent supportive housing programs. So with that, I'm going to pass it over to our Chief Financial Officer, Administrative Officer, and she's going to go over a bit some of the details with the project.
Thank you, Ruben. The total project is estimated to cost $3.3 million. The City of Modesto contributed $450,000 in Community Development Block Grant, we call them CDBG, funding to acquire the property, which Stanco purchased on April 26, 2021. The Community Services Agency, CSA, as the fiscal agent for the Stanislaus Community System of Care, CSOC, awarded Stanco $1.4 million in Homeless Housing Assistance and Prevention Program, otherwise known as HHAP, funding for the project, of which $1,238,376 will be used for development costs for this project. The remaining HHAP funds will be held in contingency reserve. There is a provision in the budget to absorb regulatory requirements inclusive of prevailing wage and other contingencies should they arise. HCD will require a third-party audit of the project's expenses once complete. BHRS recommends using the No Place Like Home and PLH non-competitive allocation funding for the remaining development costs, and that's about a little bit more than $1.6 million. BHRS has $2.3 million in No Place Like Home non-competitive allocation funds, of which we're recommending $1.4 million in change for new construction and rehabilitation costs, $222,146 for operating reserve, replacement reserve, project administration, developer overhead, and permanent financing loan origination costs. And the total of those is $1,661,032, which would go towards the development costs shown on the previous slide for the project. The remaining $638,000 would be used for the No Place Like Home capitalized operating subsidy reserve, which would cover operating costs and any deficit that's attributable to those No Place Like Home assisted units. No Place Like Home funding is unique in that HCD reimburses project costs once the project is complete. Under the No Place Like Home, funding for construction and rehabilitation costs cannot exceed the multifamily housing program per unit loan limits, which has been challenging as well with the construction costs and prices that Ruben has talked about earlier. As he also mentioned, with the HCD funding being provided as reimbursement, it poses a challenge. And Stanco does not have the financial means to carry the cost of a construction project of this magnitude until completion, and their business model does not support qualifying for a standard industry construction loan. Behavioral Health and Recovery Services, the Chief Executive Office, Auditor Controller, and Treasurer staff considered several potential options, and staff are now recommending that the county provide an interest-bearing bridge loan to facilitate this project moving forward. It is recommended that the county provide an interest-bearing bridge loan from the County General Fund in an amount not to exceed $1,438,886 to Stanco to cover a portion of the rehabilitation, development, and construction costs of the project until Stanco completes the project and is reimbursed by HCD.
The auditor controller will calculate monthly interest based on the most recent average annual rate earned on the county's treasury pooled cash. The auditor controller has estimated accrued interest will be approximately $51,000. However, interest rates may vary, and the bridge loan will be secured using the property itself at 835 California Avenue in Modesto as collateral should Stanco default on the loan. The bridge loan, including the promissory note and deed of trust for the property, will be fully executed once the project is ready to begin so that we can avoid unnecessary interest costs accruing prior to the start of construction. Stanco will repay the bridge loan and accrued interest once rehabilitation and construction work has finished, and HCD provides the No Place Like Home non-competitive allocation funding to Stanco. It's anticipated that the bridge loan will be repaid by June 30th of 2023. So we have 5 staff recommendations for you, so I'll go through those. Number 1, acknowledge the partnership between Behavioral Health and Recovery Services, Stanislaus County Affordable Housing Corporation, and the City of Modesto to acquire, rehabilitate, and develop a property located at 835 California Avenue, Modesto, California Avenue project, to create 7 permanent supportive housing units. Number 2, approve the dedication of No Place Like Home non-competitive allocation funds to Stanco in the amount of $2.3 million for the California Avenue project. Number 3, approve an interest-bearing loan to Stanco of an amount not to exceed $1,438,886 from the County General Fund. Number 4, authorize the auditor controller to release the funds when they receive the executed promissory note in the amount of $1,438,886 and the deed of trust for the interest-bearing loan to Stanco due on June 30th, 2023. And number 5, authorize the auditor controller to extend the date for repayment of the $1,438,886 interest-bearing loan from the County General Fund to Stanco as provided in the promissory note section 1B in the event that the NPLH non-competitive allocation funding disbursement is delayed. And with that, staff are available for questions should you have any.
Very good, thank you. Questions for staff? None. Okay, I guess I'm going to just talk a little bit. It's too bad that Jim wasn't here. Jim left.
I think everyone's going to have comments.
Okay, oh, I'm sorry, okay.
Questions.
Okay, yeah. Any questions from the public with regard to this? Okay, we will bring it back to the dais. Okay, now, comments.
Yeah,
Peter,
sure.
go ahead.
Yeah, it's funny because after receiving our briefing, I wasn't sure what I was going to say about this project, and I had, and you speak of Supervisor DeMartini, when we initially looked at this, the cost on a per square foot basis is just astronomical, and it turns into kind of a bitter pill, except for the fact that I sit and always go back to the same premise, and I think we talked about it, I heard it earlier today, is that we don't want money going back to the state government. We want it spent here in Stanislaus County because the issue is still going to be the issue, with or without the 6 houses. So we're better off with it being built, regardless of the exorbitant price. But again, it is a little bit of a bitter pill. What I really like about the project, again, on site, we have partner Stanco, City of Modesto. Partnerships are always good. The county this isn't our bailiwick, obviously, to build something. So thank you to Stanco for being willing to do this, and to the City of Modesto for purchasing the land using their CDBG funds. I also like the fact that, again, on site, we're going to have supportive services and peer support and case management. What I've seen, and again, it's not quite apples to apples, but the Empire Cold Winter Shelter, we have so much case management going on for homeless folks that we see this very, very high avenue of people making it into housing on their own, but they need to start, right? It's the hand up. And I see this as the same thing. As long as we have the ability to provide those services on site, it makes a big difference. I'll be voting for it. Again, I have to hold my nose, but I know that if we give the money back to the state, another county's going to take it. They're going to do the same thing and improve their county situation, and I want to do this here in Stanislaus County. Those are my thoughts.
Okay, thanks, Vito. Anybody else? Buck?
Thank you, Mr. Chairman. Ruben Kerr, thank you for your report. And I'm probably just echoing what Supervisor Chiesa said. The cost is the cost, is what it is. The need is there. We have partners willing to work with us to get it done. And going back to we have a count of 200 interdepartment count of people needing services that are either unsheltered or in low barrier shelters.
They're actually open to our treatment programs. They're on our caseloads, they're getting services, and they're open to us. These are not folks that we need to do outreach to. They come to us for services, or we're going to them for services, and we regularly see them. They're homeless, though.
Yeah. So again, the need's there, and overabundantly.
Correct.
So we need to do more projects like this, and I'll be voting for it.
Very good. Thanks, Buck. Okay, I'll just kind of end this here with, so thank you for presenting this. And like I said, I wish Jim would have been sitting here to see this. And Chance, back in the day, we'd get some pretty rough comments from Jim with regard to these costs when you look at the square footage cost per square foot for us to do this. And it is tough. It's tough to do this. But the only way for us to get anywhere, we always say, maybe it's I always say, we can't build our way out of our homeless problem. We need to get services to people, and that's the only way it's going to work. And so you've got 291 people that you're working with mental health issues, and they come in and see you, then they go back and sleep on the street that night. And so how does that work? It doesn't, right? We're not going to, be able to help people if we don't have places to put them. And as Vito said, we thank Stanco for partnering with us in the city of Modesto for buying the land. And I know this is how it's frustrating that it is so expensive, and a lot of it is just the cost of construction that's happened now, and I know this. But we're just not going to make any progress. We don't want to lose the funds. We're not going to make any progress with people with mental health issues if they're out on the street, so we've got to get this permanent supportive type of housing going. As frustrating as it is how much it costs. But I think there is some hope out there. We're doing this one this way, but I think there's some potential out there for other ways for us to do that. And I don't know if, Ruben, you want to address that a little bit about some future projects potentially that we might work on and different ways that we might be doing this.
Yeah, definitely. So as I stated in my opening comments, this is a new construction project, and as far as additional projects in other ways that reduce the cost, and I'm saying that with some caveats that reducing the cost compared at this moment in time because of the cost for materials and labor a year ago or 2 years ago, we could technically find another hotel to rehab, but it's still going to be inflated costs from 2 years ago. But at least comparing projects at this point in time, there's the way we would go about doing that is finding current apartment complexes, hotels, where we rehab them, and we find ways to build partnerships along that lines. I mean, we're actively working on those types of projects on a weekly basis now. Given that there is now resources coming in this fiscal year as well as next fiscal year now to build out and rehab these types of projects. I'll say one more thing. We're not only looking at this county-wide. I regularly meet, and I actually have a meeting today with the directors of San Joaquin County and Merced County. And we're also looking at what could we do regionally. And that's another strategy that we have in terms of how do we partner in some of these residential treatment programs where folks do need some treatment, and not just supportive services, it's supportive service housing. But we do have, for instance, transitional board and care and that type of housing that we also need to continue to look at. So those projects we're looking at regionally because you do have more, it's a different population. So anyways, I would say that yes, it's going to take more projects like this, but also other projects like we've done in the past that have been able to get ramped up pretty quick and at lower cost compared to new construction sites.
And I think the key is partnerships, just as with Stanco, we're looking at other partnerships. We've got organizations out there that as a county we are funding and help fund right now that could be good partners with us in this, in addition to what's going on here. So.
Definitely, the developers and being able to put projects together, that's another area that we continue to look for additional partners to help out with that. especially with the amount and the pace that we're going to have to work over the next year or two to really take advantage of these resources.
Yeah, without losing them. Okay, very good.
Can I acknowledge one other thing that I forgot? That's, this is new construction. It's not us going out and purchasing a house that's currently built and taking it out of inventory. And we know inventory is short for single-family housing. And I always have to acknowledge that because government money coming in and buying houses against private citizens doesn't make it any easier. It makes it more difficult. So and that's been brought to my attention, and I do acknowledge that this is new housing.
And one quick point on that is some of the work that we've been doing is more along the hotel route, though. Yeah. So, and smaller hotels, so that it is a different in that area. So.
Very good. Thank you. Okay. Any other questions, comments? Okay. If I see none, then I will. Any comments from anybody else in the audience? Okay. See none. Bring back to the board for a motion.
Motion to approve.
A motion. Do we have a second?
Second.
All in favor?
Aye.
Opposed? Passes unanimously. Thank you, guys. Kara, Ruben, thank you very much. Okay, we will move on to our correspondence. Oh, I'm sorry. Okay, thanks, Steve. See you. We did have one public comment came in late that we still can do this if that individual is still around. Bobby Christolakis? Is Bobby Christolakis still here? Okay. You going to check, John? Just see. Okay. Well, hold on one second. Give him a second.
I got onto the Houston City Council meeting last night at 7 o'clock. They start at 7, and they changed their start time to 6 in December, and so there was,
It's done,
I
huh?
don't know what I was thinking.
It was
So
over.
I understand when people are
Yeah.
caught up.
Okay, let's see if John comes back with him or not here. Okay. You got any good jokes? Okay, John's gone. All right, sorry. Bobby's gone. Very good. All right, so we'll move on to our correspondence.
This board has received the correspondence and claims as noted on the agenda.
Okay, we're going to change the way we do this. Acknowledge receipt of correspondence and refer as recommended on the agenda. Any Board of Supervisor reports?
If I could just, and I know that I'm no longer on the Transit JPA, but and I see Stephen out here, the transition from START and, well, I guess it's the providers. The providers, and STORE was the county's provider, but when we transitioned over, TransDev has taken over. And I know there have been some pretty serious hiccups. There's a shortage of transit operators, actual drivers. And so we just ask that people give us a little bit of grace. It wasn't as smooth as we would have liked, but they are working diligently on it because there's been some pretty excessive wait times throughout, and I've been getting some complaints. So I just wanted to acknowledge that.
Right, no, that's a good point. There have been a lot of issues out there they're working on, and as everybody, they're shorthanded. And yeah, I'm glad you. Very good. Okay. Any other no other Board of Supervisor reports? Legislative, fiscal, and management report. Chief Executive Officer.
So just real quick, no specific items of legislation as the legislature is still preparing to introduce new bills and so forth. However, I do want to acknowledge that we've seen a variety of news reports over the last week of groups of legislators preparing the introduction of some pretty significant legislation in the next month, and we'll report back to you when we see that. And I also want to just mention that while we were here in this meeting today, that we did see, it appears that there are some agreements happening at the state level to provide COVID payments to employees who are missing work. So we'll figure out what that is, and we'll report out on it at our next meeting. Thank you.
Okay, very good. Thanks, Jody. I want to thank John Gingrich for being here today. Thank you. Long meeting. We appreciate you being here and all you do. Appreciate Stephen staying around, Yvonne, and you for staying around too. So anyway, if no other business, this meeting is adjourned. Oh, we will adjourn. We're going to go into closed session, and Tom will report on closed session.
Yes, we have 2 items for closed session today. We have a conference with legal counsel, existing litigation pursuant to Government Code Section 54956.9, that's subdivision D1. We have 1 case there. It's Matthew Ford versus Stanislaus County et al. Stanislaus County Superior Court case number CV 00017, and conference with labor negotiator pursuant to Government Code Section 54957.6. Agency negotiators is Jody Hayes, Tamara Thomas, Kara Vink, Burke Dunphy, and the Labor Organization of Service Employees International Union 521.
Very good. Okay, well, it'll be appropriate, I think, to ask if there's any comments with regard to closed session. Seeing none, this meeting is adjourned.